Great. Good afternoon, everyone. Welcome today to the Royal Society of Medicine's The Big Bowel online event 2024. Apologies about the lack of camera. We're just trying to sort that. As many of you know, the RSM is one of the UK's leading providers of continuing learning for healthcare professionals, and our focus is about bringing people together to have the medical conversations that matter. Today's event, I'm delighted to say, is jointly organised with Bowel Research UK and brings together patients, members of the public and researchers to explore current research into bowel cancer and bowel disease during this half-day webinar. I am thrilled to introduce Sam Alexandra Rose, who is Patient and Public Involvement Manager at Bowel Research UK and the current host of the Charities podcast, Can I Butt In? She is a 3-time cancer survivor with constitutional mismatch repair deficiency due to inheriting Lynch syndrome from both parents. Sam is also a PhD student at Teesside University, exploring the connection between creative writing and cancer survivorship. She is the author of memoir Gut Feelings, Coping with Cancer and Living with Lynch Syndrome, and the only book currently published on CMMRD, the CMMRD book. Sam, thank you so much for coming today, and over to you.
Thank you very much, Amanda. Good afternoon, everybody, and thank you for coming to the Big Bowel event 2024. As Amanda said, I'm Patient and Public Involvement Manager at Bowel Research UK. If you're not already familiar with Bowel Research UK, we are a charity funding vital research into bowel cancer and bowel disease. I'd like to give a nod firstly to our patient network called People in Research Together, or PART, and encourage you to join. The PART network is a group of patients and members of the public who get involved in research into bowel cancer and bowel diseases through things like focus groups, surveys, reviewing documents and so on as people with lived experience. It's a great opportunity to help shape future treatments and care for yourself and others, to find out about the latest developments in research, to give back to the healthcare community and be part of the patient community, and to take part in Bowel Research UK campaigns, share your story and be the first to find out about events like this one. You can join the PART network using the QR code shown on the screen right now, or by going to bowelresearchuk.org. And if you'd like to get in touch, including if there's any researchers among us today interested in engaging the PART network, you can email part@bowelresearchuk.org to contact me. And you can also support the work the charity does and help to end bowel cancer and bowel disease by making a donation at bowelresearchuk.org. So it's lovely to see so many people here. We've got a really great afternoon lined up, which we're delighted to bring to you. So I'll run through the agenda now for you. And as Bowel Research UK funds research into many different types of bowel disease as well as bowel cancer, we're hoping that this event reflects the same diverse range of topics, and that it'll be a very interesting afternoon. So each of our sessions today feature 3 speakers, including 2 researchers and 1 patient advocate, and each session will finish with a Q&A. We have 3 facilitators here today to guide us through these sessions. Our first session in just a moment will be on diverticular disease. Then at 2:05 we'll have a session on the gut microbiome, and we'll then take a short break and return at 3:25 for our final session on surgical and interventional science, including talks on robotic surgery and fecal incontinence, and then we'll wrap up with some final words. So all the sessions take place at this same link, so stay right here or dip in and out as you wish. If you have any questions for our speakers, please put them in the Q&A box only. We won't be using audio for this, so just pop them into the Q&A box. You'll find it at the bottom of your screen, and you can do that throughout the whole session, so you don't need to wait until after the speakers have finished. And you can also upvote questions, so if someone has said something that you'd like to see answered, you can click on the thumbs up next to it to like it and put the question further up the list to get answered. So that's enough from me for now. Let's get stuck into our first session, which is on diverticular disease. And this is facilitated by Julie Thompson, who is specialist dietitian in gastroenterology and information manager at Guts UK Charity. So Julie, over to you.
Hi everyone, welcome to the hour on diverticular disease. Now, as Sam has said, we've got three really interesting talks for you. I'd like to thank Sam as well for having a session on diverticular disease. It's an area, that there's a lack of research, and it's really important that people get information on it. So this first session is on the Diverticular Disease Priority Setting Partnership, and I'd like to welcome back Sam Alexandra Rose, who's the Patient and Public Involvement Manager at Bowel Research UK, and I'd also like to introduce Helen West. Now, Helen is the Patient and Public Involvement and Engagement Officer at Guts UK Charity, and she's got a long history with Guts UK, raising funds as a supporter for the charity for over a decade before joining the team as Patient and Public Involvement and Engagement Officer in 2021. Helen is passionate about ensuring that the patient and carer voice is heard throughout all areas of the charity's work, which covers digestive conditions top to tail. Helen is extremely proud of the patients and carers she works alongside, admiring their bravery and honesty as they share their lived experience to help inform future direction and drive important change. As part of the Research Awards Committee, the impact of the patient and carer's voice has changed many directions on research. Helen has set up the Expert by Experience panel at Guts UK Charity, putting patients and carers at the forefront of key decision making at the charity. The Diverticular Disease Priority Setting Partnership is the third priority setting partnership that Helen has undertaken for the charity, following the success of two other PSPs, one for pancreatitis and one for irritable bowel syndrome. So over to you, Sam and Helen.
Hello. Firstly, I'd just like to thank everybody for joining today. It's absolutely wonderful. So thank you. And thank you for the introduction, Julie. I'd like to introduce our Diverticular Disease Priority Setting Partnership that we're working in collaboration with Bowel Research UK and ourselves at Guts UK. Yeah.
Okay, so before we get into the priority setting partnership and what that is, I'd like to give a very brief overview on what is diverticular disease. So diverticular disease is caused by small pouches or pockets that appear in the wall of the bowel. So when it's just one of these, they're called diverticulum, and when there's several, that's diverticular. And these tend to develop as people get older. So it's often seen as a condition that affects older people, and it can cause symptoms, doesn't always, but the symptoms are as follows. So you may have intermittent belly pain in the lower left side, not always the left side, and I'll get into that in just a moment. There may also be constipation, diarrhea, bleeding, and tenderness in the lower left side of the belly as well. Although the tenderness and the pain does also sometimes appear on the right hand side instead, and that's especially in people of Asian ethnicity. So that might be on the lower right hand side rather than the left hand side in some cases. Other symptoms are bowel incontinence, and diverticular disease can also lead to complications for up to 15 to 25% of people. So that can include things like bowel obstruction, perforation, bleeding, abscess, and fistula. So as you can imagine, or may have even experienced, it can be a very difficult condition to deal with.
So what do we know about diverticular disease? One of the reasons that we're undertaking this priority setting partnership is because we don't really know a lot about diverticular disease. And if you're out there suffering from it, you will understand that there is not a huge amount of knowledge or research that has already been undertaken on diverticular disease. So often patients may not have any symptoms, and this is where it's called diverticulosis, or they may experience symptoms, which is diverticulitis. So that's where the two names come into it. What we do know, though, is over nearly 161,000 people are admitted into hospital with diverticulitis in England in 2020. So we know it affects a huge amount of people, and we also know if it affects, and people have to be admitted into hospital because of it. We also, what we do know is that around half the population of the Western countries over 50 have diverticular in their colon, and we know that this is rising to at least 70% by the years of 80 years of age. We do know that there is a rising number of young people that are affected by this condition. So, this is becoming really important to find out. It's always been led to believe that it's an older person's condition, and actually we're realizing more and more so that actually it's definitely affecting the young. So another reason why, we need to get a much better understanding and a treatment and care plan put in place. We also know that 1 in 3, it was 1 in 3, and it's now increasing to 1 in 2 people will be affected during their lifetime with diverticular disease. So again, really important that we get to understand this condition better.
So that's what we do know about diverticular disease. And there's an awful lot, as Helen said, that we don't know. Considering those figures that Helen just ran through, it affects an awful lot of people, and yet not much research has actually been done into it. So there's lots of things that we don't know about how and why it develops. So what are the causes for diverticular disease? And why is it rising in younger patients? And what are the best treatments that we can give to people to help with this? So what we need to do with this priority setting partnership then is to have a look at all of the unanswered questions that people have around diverticular disease, and find out what those are and prioritize those into an order of making sure that researchers are researching what is really important to patients, healthcare professionals and carers and families as well.
So what is a priority setting partnership, and why is this so important? So the priority setting partnership is facilitated by the James Lind Alliance, and they are a non-profit making organisation that is funded by the National Institute for Health and Care Research. What we're looking for is part of that is that we're looking at finding out what the 10 top research priorities are that are wanted and need to be answered by, and this comes together with healthcare professionals and patients and carers. We bring together, part of the James Lind Alliance initially is that we bring together a steering group, and this is made up of 16 people, and 8 are healthcare professionals and 8 are patients and carers. So it's all on equal footing. No one has everybody is of equal value. There is no one better than anybody else on the steering group. So we put together the steering group, but initially we make a protocol which shows what the areas that we want to make sure that we cover. So our protocol on the diverticular disease was about diverticulosis, diverticulum, and complicated diverticular litis. So we needed to make sure that all came together. What we're seeking is to find the unanswered questions that have never been answered, and we do this by having 2 surveys, and the first survey we've just closed, and we had over 3,000 questions. So we know that this is even more of a popular and wanted answers from the questions that we received. So once we've checked all the questions to see if any of them have already been answered, and we check the uncertainties, that then gets put together for a final survey. And the final survey will probably have approximately 70 questions, and then we take it to a final workshop, which again is attended by healthcare professionals and patients and carers on equal footing to come up with the final top 10 research priorities.
So why Bowel Research UK and Guts UK then? So the PSP is equally funded by both charities, with Helen as the lead and myself as the coordinator. We're charities, as you can see by our name, Bowel Research UK, focusing on research, and Guts UK has a great track record and reputation for patient support and information. So we cover both aspects really, and it's been a good partnership to cover all of those bases. And as Helen said, we're seeking to discover those unanswered questions from everybody. And there aren't actually any other charities that are currently focusing on diverticular disease. So yeah, I can't really stress enough. This is an unmet need and a gap that we're filling together.
As rightly said, we are the only charities that are covering diverticular disease, and which is why it's so important for us to be able to do this and collaborate together on a PSP. Why are we doing the PSP? We know that it's underfunded and we know it's under research, and it's really clear, as we've previously said, in the figures that are being produced, and for the amount of questions that we've already received from our first survey. There's never been a priority setting partnership done in this condition. It was really important that we did a PSP because it's of equal voice. As I said previously, everybody has an equal voice. And making the funding and conducting health research awareness, which affects everybody. So it affects the patients, the carers, the clinicians, and also priority setting partnership is recognised by the NIHR. And so if there's any researchers out there that's listening to this and they're interested in doing research on diverticular disease, it is very much recognised for funding through the NIHR.
So where we are now then, as Helen said, we put out the first survey, which aside from taking some demographic information, really only has one question, which is what would you like to see answered by research into diverticular disease? And so we had 1,612 people responding to this survey, and many people asked more than one question, which is brilliant. So we've had nearly 3,400 questions, which is an awful lot of data to be trying to get through. So we've been analysing these responses with an information specialist and with a data subgroup from our steering group, and we're looking to create a second survey from that. So the process that we're in at the moment is having a look at all of the questions that we've received so far and grouping those into themes. As you can imagine, a lot of the questions, like some of them will be the same or very similar, people asking the same sorts of questions, or under the same kinds of ideas. So we'll be grouping those into different themes. We'll also be looking at which questions are in scope and out of scope. So the out of scope questions may be perhaps they don't completely relate to diverticular disease, or maybe they've been asked by people who are living outside of the UK. This is a UK based survey. So those are the kinds of things that we won't be putting in the final questions. However, these are still very useful. They won't be discarded. They'll be set to one side and they may be useful for other projects. And then there may also be questions that have been covered in previous research. So these are things that we may already know the answers to. So we won't be putting them forward as questions because they've already been researched. Again, we'll be putting those to the side because I think it's also very valuable to know that, yes, while there may have been research and we may have the answers, not everybody is aware of the answers. So that's a good indicator that information needs to be better distributed so that people understand more about their condition and their care. So it's all really useful information, even if it isn't going to be included in the list of questions. So we take these questions and we whittle them down to a smaller list of questions, and then that's what we use for the second survey, which will be going out in a little while once we've done our analysis. And that second survey will be asking people to prioritize those questions, and then we'll whittle them down a bit further. And then in our final workshop, which will be an in-person event next year, we'll be gathering people, again, patients and patients and clinicians, to create those that top 10 list of research priorities. And then the idea is that researchers can come and they can have a look at those questions in the future, and they can see, these are the questions, these are the things and priorities that are important for patients, families, and clinicians. This is what we should be researching. And in that way, the end of the PSP is actually really just the beginning of the work. So we're setting the foundations for future research into diverticular disease, so that future researchers have that information available and they're researching something that's going to be really useful and helpful for people with diverticular disease and the people who care for them.
So you're very welcome to find out and keep ahead of what where we're at you can either email myself or Sam if you have any questions that you would like to ask, and also if you're interested in taking part in our final workshop. So if you're interested, please contact us, and we will certainly put you forward for our final workshop. But I'd just like to thank everybody, particularly Sam, for putting this together, and look forward to hearing any questions if needed. Thank you.
Thank you very much. Yeah, happy to answer any questions at the end of the session.
Thank you so much, Helen and Sam, for that. It's a really, really important work for the PSP. So yeah, do keep in touch with all that Bowel Research UK and Guts UK are doing in respect to that. Please do put your questions in. There are quite a few questions that are coming in through at the moment, so we can have a look at those at the end. So the next session we have Linda Griffiths, and Linda has been nursing within the NHS for the last 41 years. She therefore understands the pressures that everybody works with. In her current role as lead nurse for the Congenital Heart Disease Network in the northwest of England, she's responsible for public engagement and understands the powerful testimony of patient stories. Today, she's here as a patient and is keen to share her own story of diverticular disease and how she ended up having to have emergency surgery. She's very grateful to the NHS for saving her life, and is keen to share what happened to her. She now volunteers for the Colostomy UK charity, helping to listen and support other people who are living with a stoma. She's proud to be on the steering committee of the James Lind Alliance Priority Setting Partnership, looking at the top 10 priorities for research into this common but poorly understood condition. Over to you, Linda. Thanks.
Brilliant, thank you. So I'd like to start by saying thank you. Thank you for inviting me to join your meeting, especially to Bowel Research UK and the Royal College of, or the Royal Society of Medicine, and just having the opportunity to talk to you all about what's happened to me and my bowel problems. So over the next 10 minutes or so, I'm going to tell you a little bit about me, my personal journey with diverticular disease, and then bring you up to date with how I'm doing now and what's happening. So if you can go to the next slide, please. So this is me with my 2 adult sons and girlfriend. As you can see, I'm very active. I enjoy walking and traveling. If you can just click again for me, I do a bit of knitting and click again. And during COVID, I decided that I needed to improve my fitness. and I started the Couch to 5K programme, and I joined a ladies running club in Formby, and I've got the fantastic privilege of being able to run around the pine woods and the beach close to where I live, and this is a picture of where I do my running. Next slide, please. I'm also a nurse. I started my nursing career back in July 1982, so it's actually just over 42 years ago now. As has already been mentioned, I look after people with congenital heart disease or a heart problem that you've been born with. And I've been doing that since 1985. I'm dual qualified as both a paediatric and an adult nurse, and I've been in the unique position, I guess, of nursing adults who I actually nursed as children and tiny babies as well. I'm now the lead nurse of the network, so the all-age North West of England, North Wales and the Isle of Man Congenital Heart Disease Network. I focus primarily on quality improvement, patient engagement and clinical governance. And I'm hugely grateful to the NHS for providing me with a fantastic career and having so many opportunities to make a difference. And of course, more recently, I'm even more grateful to the NHS for saving my life. Next slide, please. So if I may, I'm just going to start quite a long time ago, in fact 33 years ago, when my firstborn Andrew was born in 1991, and this is him. At that time I suffered a nasty posterior vaginal wall tear, which was repaired at the time, but resulted in me losing the feeling in my bottom for about 8 weeks after I'd delivered. And although that gradually improved, I was left with terrible urgency. Now, thankfully, I only needed to go to the toilet once in the morning, so it didn't really affect the rest of my day. It was just my poor husband, really, that had to put up with me banging on the toilet door in the morning in desperation to go to the loo. So I managed to live with that, and I doubt there's even any record of that in my medical notes. But over the coming years, I started to develop intermittent flare-ups of pain. They were always in the left side of my tummy, and that coincided with needing to go to the toilet more often, which meant that my problem with urgency was actually more difficult to manage, and that took me back to my GP. And I had a colonoscopy performed at the time, which was reported as being normal, apart from some diverticular pouches that were noted. And so I was diagnosed as having irritable bowel syndrome back then. And I learnt to live with those flare-ups. I just put it down to a functional problem that I had to manage, and I got on with it. Next slide, please. Until 2015, that was, when during one particular flare-up in work, I was doubled up in pain, and the consultant that I was in clinic with mentioned that I looked awful and that I should go home. And she persuaded me to have some bloods done before I left, and my CRP, my ESR, white cell count, bilirubin, all of my sort of infection inflammatory markers were elevated. And I went home, and I was summoned to see my GP the next day and was told off for going to work when I was so poorly. And that was the first time that I was told that I had diverticulitis, and I was given a course of antibiotics. I was eventually prescribed rescue antibiotics in 2018. I wasn't really given any guidance as to when to use them, but I concluded myself that unless my temperature was over 38 degrees, that I shouldn't really take them. And so I didn't take them very often because I didn't often have a high temperature. Next slide, please. So in October 2020, so we're now during COVID, I woke in the middle of the night with a really bad episode of abdominal pain and vomiting, and I did have a temperature of over 38 degrees. I felt absolutely dreadful. I started my antibiotics straight away, and as you can imagine, during COVID, I couldn't get a face-to-face appointment. I did manage to get several telephone consultations with an advanced nurse practitioner, and I ended up having 3 courses of antibiotics over the next 3 weeks. She also arranged for some bloods to be done, which was great, but they didn't get taken until the last day of my 3rd course of antibiotics, which of course came back as normal. So I continue to have symptoms quite regularly now. I would say at least once a month. It's really difficult to get a face-to-face appointment during COVID. And in the June 21, out of the blue, my GP called me. They were wanting to do a telephone review of my HRT. And of course, all I wanted to do was talk about my bowels. So I think to shut me up so that he could get on and do what he wanted to do, which was to review my HRT, he agreed to see me the next day. And he did see me the next day, and he took a full history, examined me properly, and he was quite concerned about what he'd found. And he was really worried about my weight loss and ordered an urgent colonoscopy. Next slide, please. So I had the colonoscopy, and the results confirmed diverticulosis and described my sigmoid colon as being severely narrowed and tortuous. In fact, they had to use a paediatric probe to do the test. and I was discharged back to my GP with no follow-up planned. My GP was frustrated about that and attempted to make an urgent appointment back with the colorectal team. That referral was rejected, and he was told that diverticular disease is managed in the community only, but they could offer me an appointment with a specialist nurse to help me manage my symptoms. And I eventually got that appointment to see the specialist nurse, but unfortunately they only gave me 48 hours notice, and it clashed with an important meeting in work, and I couldn't easily cancel that meeting. And given that I've got a nursing background, I sort of understand what diverticular disease is. I chose to cancel and rebook that appointment, which in hindsight, maybe I shouldn't have done. But that was then rebooked for the January 2022, which ended up being after my emergency surgery. Next slide, please. So I continued to have symptoms. They were the same each time. I would start to have more bowel movements that were very narrow bowel movements of a soft stool. So it was like I was passing a pile of worms. The stool continued to be of a soft consistency throughout. My bowel movements would then stop completely, and that would be accompanied by severe abdominal pain on the left-hand side. I developed a large lump that was palpable, and it was agony to touch. I'd have to resort to a liquid diet until it settled down, so I was gradually losing more and more weight. I was never constipated. I've never had a hard stool that I can't pass, although that's what my medical notes state was the issue. I expressed my fears to my GP on numerous occasions that I thought I was going to end up in A&E with a blocked bowel. He was equally frustrated and agreed, but seemed powerless to do anything about it, as he tried to refer me for a specialist opinion, but it had been rejected. So following a further episode in the November 21, I was seen by a different GP who was really concerned after feeling the lump, and so referred me to gynecology under a 2-week cancer pathway. Given that nobody seemed concerned about my bowels, he wanted to make sure that we weren't missing anything nasty from a gynae perspective. And so I was seen by the gynae team within the 2-week period, who reassured me it wasn't gynae related, but they were equally worried and requested an urgent CT scan, which was performed on the 23rd of November of that year. And that scan was performed at the Regional Cancer Specialist Hospital. Next slide, please. So I received a call back about a week later after my scan to be told that the scan had suggested that I might have a malignancy in the bowel wall, and that it had probably spread to the mesenteric lymph nodes, and that they were going to refer me urgently to the colorectal team. The colorectal team decided that a repeat sigmoidoscopy was recommended, and that was planned that week. As you can imagine, during all of this, I was still trying to run the Couch to 5K. And I was due to graduate and reach my goal of running that 5K on the Friday morning or the Friday evening that I received this news that I might have cancer. I decided that I was going to do that 5K come hell or high water, and I did manage to meet my running goal of running 5K that night. And then on the following Monday, I took my bowel prep properly, as advised, but by 11 p.m. that night, I hadn't passed anything. Not even a puff of wind. I knew I was in trouble. I got rushed to A&E. My repeat CT scan in A&E was initially reported as a malignancy also, and I was told by the doctor in A&E that the tumour had blocked my bowel. By 8 a.m. the following morning, I was going for emergency surgery by the general surgeon covering A&E. And just before my operation, one of the registrars came to see me, and he did say that it might not be cancer, but obviously we'd have to wait for the histology report to come back afterwards. I know that the radiologist who'd performed that CT scan in A&E had called the colorectal surgeon at the hospital about my CT scan result and the possible cancer diagnosis. And I also know that that colorectal surgeon had then called the general surgeon during my operation, as he wanted to make some recommendations, but the surgeon by that time was just about to close me up, having performed a Hartmann's procedure. Next slide, please. So I woke up with a stoma and I spent about 7 days in hospital. Eventually my histology came back as clear. It said that although there was no mucosa present within the areas of abscess formation to confirm this, that they felt that the appearance was more in keeping with complications related to diverticular disease. So I'm sure you can imagine that that was amazing news to hear. Although at the time, I have to say, I was a bit all over the place as I felt so unwell, and I was coming to terms with having had emergency surgery that was life-saving, but also life-changing as well. Next slide, please. But I did recover really well, and I'm convinced that my underlying fitness helped with that. I was invited back once to see the general surgeon in a post-op clinic and was discharged. So I've gone through all of this and I've never actually seen a specialist, and I'm now not under any follow-up moving forward either. I am learning to live with my stoma quite successfully. I feel frustrated that I had lots of opportunities to be seen by a specialist to manage my condition. And if surgery was still necessary, it could have been maybe a planned procedure rather than an emergency one. I don't feel I've ever had a full detailed medical history taken apart from that first one with my GP. I'm surprised that my medical notes suggest, or I'm frustrated really that my medical notes suggest that I was constipated and that this was somehow a contributing factor. I've never suffered from hard stools that I cannot pass. I've always had regular bowel motions and soft stools. I'm quite fit and active. I'm not overweight. My diet is healthy. I don't eat any processed food. And I feel like my risk factors for developing diverticular disease are quite low. My mother also ended up with an emergency operation and a stoma due to complications related to diverticular disease. And it looks like my sister is potentially suffering in the same way. So I guess I'm always going to wonder if diverticular disease is something that's running in our family. I've never been asked about that. I've never had the opportunity to explore any of these questions. And as a patient, it feels like no one is really interested in diverticular disease and that it's the poor relative of colorectal disorders. And then when I eventually saw the nurse specialist in January after my surgery, it turns out that that was an appointment to see a nurse consultant and not a nurse specialist. That wasn't made clear, as even the appointment letter stated that I was going to see a nurse specialist. And when I recounted my story to her, I was just told that, well, I should have rocked up to A&E at some point during that last year, instead of waiting for it to become an emergency. And I was slightly frustrated with that because it doesn't seem a really the best use of NHS resources to me. Next slide, please. And so that's why I'm so keen to be on the steering committee of the James Lind Alliance Priority Setting Partnership that you've just heard Sam and Helen talk about. I'm really excited to see what the final top 10 priorities for research into this disease are going to be. And I'm hoping that that will result in a better understanding of how to identify and treat this awful condition. Next slide, please. So finally, I've been determined to get back on my feet. I started running about 6 months post-op at the grand old age of 60. And I managed to run in the local Santa 5K dash 1 year after my surgery. And I'm back running with my ladies on the beach as well. And I do feel better than I've felt in a very, very long time. I'm also not keen to consider a reversal, and I know that's an option for me, as I'm not confident that anyone is interested in taking the full history and is going to take my urgency and possible birth injury into account. So for now, I've opted to live with my stoma, and I'm quite happy with that. Next slide, please. And so that's the end of my story, and I'd just like to say thank you for listening patiently to it. It does mean a lot to be heard and to be understood as well. And I hope that in the future this condition gets the recognition that it deserves, and that research becomes a top priority to ensure that everyone affected is offered evidence-based care to give them the chance of having the best outcomes. Thank you.
Thank you so much, Linda. I'm so happy you're feeling better, and it's so important for us to hear the patient's story, particularly with this condition. So thank you so much for sharing that. So the next session is from Mr. David Humes. Mr. Humes heads a research group focusing on the use of routinely collected data to study the occurrence and consequences of surgical disease, alongside delivering studies on the use of novel interventional and diagnostic devices. He's supervised 6 PhDs to completion, and his current research group includes 4 PhD students, 2 National Institute of Health Research academic clinical fellows, and a data analyst. He's been awarded over 3.6 million in grant funding and published 112 peer-reviewed publications with a current H index of 41. He's implemented the symptomatic fit pathway in Nottingham, and this is an active research area currently using the national and international data. He's completed his PhD in diverticular disease and was clinical lead for the recent NICE guidelines. He's current research lead for the Joint Committee on Higher Research Training and Academic Career Development lead in the NIHR BRC in Nottingham. His clinical practice focuses on robotic colorectal and anal cancer surgery. So over to you, Mr. Humes.
Right, well, good afternoon. Hopefully you can hear me okay there.
Yes.
Brilliant, that's great. Thank you very much for the introduction and for the invitation this afternoon to speak. That was a really fantastic presentation from Linda just before me, and unfortunately is a common occurrence for patients with diverticular disease. What I'm hoping to do today is talk to you a little bit about what diverticular disease is. We've already had some information about that, and then highlight why it's important and why it's going to become increasingly important over time. And then I'm going to talk a little bit about the evidence there is that we currently know about for treatments in diverticular disease. And that largely focuses on the treatment of acute diverticulitis and complicated disease, which is the kind of tip of the iceberg of the patients with diverticular disease. And then talk a little bit about future research. So we've heard diverticulosis is a condition of the large bowel. You can see that drawn out schematically here, and there's these small pockets that come off the bowel called diverticulae, and the lining of the bowel that's been forced through the bowel wall. And then the presence of those is known as diverticulosis. You can see them here on an old-fashioned study, a contrast study, where contrast has been put into the bowel, and you can see these pockets forming across the bowel, particularly on the left-hand side. And they're the root cause of diverticulosis. And when you look with an endoscope, you see these open-mouthed areas in the bowel where the mucosas, the lining of the bowel, has slipped out. And these areas can often have bits of stool in, they can be inflamed. And these are the pockets that cause the trouble with diverticular disease. It's a condition that increases with age. And typically in the West, we see most patients have it on the left side of the colon, whereas in Southeast Asians, it's typically over on the right-hand side. It's important when we're talking about diverticular disease just to get the terminology right, and so that everyone understands what we're talking about. So diverticulosis is this kind of structural abnormality of the bowel with the pockets present, but without any underlying symptoms. And that's the majority of patients who have diverticulosis or have the diverticular presence fall into that category. Diverticular disease is where you've got the pockets, but also the presence of symptoms. And typically, patients will complain of left-sided abdominal pain and a change in bowel habit to either constipation or typically looser stool. About 20% or up to 20% of patients who have the underlying structural abnormality of the bowel will have diverticular disease or the presence of symptoms. Then those pockets can become acutely inflamed, and that's known as acute diverticulitis. And that's a discrete area or discrete inflammatory process of those diverticulae that typically presents with severe left-sided abdominal pain, a fever, and the patient feels generally unwell. And often that necessitates a hospital admission, but can, in milder cases, be treated in general practice. And in complicated diverticular disease is the term reserved for the most severe form of the disease, where you've developed a complication related to the presence of the pockets. And typically those complications are either the formation of an abscess, perforation of the pocket, stricturing, as we've heard from Linda's talk, where the bowel narrows down in response to repeated episodes of inflammation. You can form a fistula, which is a connection between the bowel and another organ, and typically that occurs in diverticular disease with the bladder or with the vagina. And then you can have bleeding, which can be quite severe, and patients need to be admitted to hospital to treat that. So why is it important? Well, it's important because it represents such a significant disease burden. So this data here comes from hospital episode statistics data. And what it shows is that, in 2020, we had over 100,000 people diagnosed with diverticulosis coming through hospitals in the UK. And what that represents is people coming up for an endoscopy and the diverticular disease being found at the time of endoscopy, which is why there's a dip during the pandemic as we stopped doing endoscopy, and that's now recovering and people are receiving those diagnoses again. And when we think about the more severe forms of the disease, acute diverticulitis, which is that inflammation of those pockets, there's data here from the US on this graph here, and it shows that the numbers of hospitalizations have increased over time. This data was from 1998 to 2005. And what's interesting here is if you look at these lower lines in younger patients, they're increasing more markedly. So that increase was driven by an increase in the disease in younger patients. And we typically think of this as a disease of those older patients, so people over the age of 60, but actually we're now seeing people in their 20s, 30s, 40s with the condition. And when we updated that data recently, we found that in England, using the hospital episode statistics data, that actually there are nearly 20,000 people a year admitted with acute diverticulitis as an emergency in England. And to put that into perspective, that's about 2/3 of the patients who would be admitted with appendicitis in a year. And so this is a significant group of patients who are being admitted to hospital. And when we look at the more severe end of the spectrum, that 5% of patients who develop complications, there's evidence that the frequency with which people are experiencing those complications are increasing. So this is work from my PhD in 2009, where we used UK primary care data to look at the incidence or occurrence of perforated diverticular disease. We found from 1992 to 2005 that there was about a twofold increase in the risk of perforation in the population. And looking at more contemporary data, looking at the HES data, which codes for diverticular abscess and abscess together, you can see that the numbers of patients being identified as having a diverticular abscess and perforation has increased over time, such that about 7,000 people a year are now admitted with a diverticular abscess or perforation. Part of that is because we're now doing more CT scans, so we can accurately define who's got that condition, but there has been a general increase in admission. So it's an important disease process, and these just focus on those patients who are being admitted to hospital, not those who have been treated in primary care, of which we know there's a significant disease burden. So it represents quite a challenging healthcare area to work in, because you've got a typically elderly population, although now we're seeing those younger patients come in. These patients often have other comorbidities that make their management challenging and identify them as a high-risk group of patients. In terms of the complicated disease, a large number of patients may require surgical intervention, and as a result of which they then have to stay in hospital for a prolonged period of time afterwards, because often surgery necessitates the need for a stoma, and therefore patients have to manage that stoma after and learn how to manage the stoma. And so that puts quite a significant cost burden and disease burden on the healthcare service, and there are certainly significant healthcare costs associated with diverticular disease. So it's how this challenge, how we meet that with research and try and identify patients who are most at risk, and then how we can improve surgical interventions and medical interventions to treat these patients more effectively. And when I started my PhD back in 2005, the first thing I did was to undertake a review of the evidence of treatments in patients who have diverticular disease. And what we found at that time, we published this in the BMJ Clinical Evidence Series, was that there was a really poor understanding of the epidemiology of the condition. The majority of studies looking at the occurrence of the disease actually came from the 1950s and 60s, so they were no longer in date. They were no longer representative of the populations that we were seeing in England or globally. In terms of treatments for diverticular disease at that time, there were no randomized controlled trials looking at the effect of surgery in this group of patients, and there were no randomized controlled trials looking at the use of antibiotics in this group of patients, which was the mainstay of treatment for acute diverticulitis, but there was no evidence to support its use. So how has that changed over time? Hopefully I'll be able to walk you through some studies that have been published since 2007 and undertaken that have improved our understanding in some areas. So the first area to look at was the role of antibiotics in uncomplicated acute diverticulitis. This is people presenting to hospital with acute diverticulitis who've had a CT scan that shows they've got acute diverticulitis and no evidence of complicated disease. And there were two randomized controlled trials, the first from Scandinavia, the AVOD study, and the second from Holland, from the Davlo study. And they randomized just over 1,200 patients between the two of them. and into antibiotics or no antibiotics. And what they've identified for the first time is that they're actually a group of patients with acute diverticulitis who have symptoms that aren't severe, and patients who don't have significant medical comorbidity who could be treated without giving them antibiotics. The advantage to that is obviously that decreases antimicrobial resistance, but it's also demonstrated that antibiotics therefore are effective in some cases in patients with significant comorbidities or in those who are immunosuppressed. So looking at complicated diverticular disease, you can see here, this is a CT scan of a patient with complicated diverticular disease, and the colon is on this side here. This is the large bowel here. And you can see there's smaller areas of air and gas outside of the colon with inflammatory stranding. So the treatment of these patients used to be that they would go for surgery, straight for surgery. And now we've had a number of studies that have looked at what the best treatment options are for this group of patients and whether we can avoid surgery in some patients. We've also looked at what risk factors lead to the development of complicated disease. And there's a series of studies here which have looked at individual factors and identified them as important in the risk of progression to complicated disease. So we know from the American Healthcare Professionals Study that obesity is linked to an increased risk of hospitalization. So those patients who are obese had a threefold increased risk of hospitalization with the diverticular disease. Patients who are physically active had a reduced risk of getting complicated diverticular disease. And patients on aspirin, steroids, and opiate analgesics had an increased risk of developing particularly perforation. And we know that smoking is associated with complicated diverticular disease, with both the risk increasing the risk of hospitalization and perforation from studies that we've done here in Nottingham and also with our Swedish colleagues. So we've identified some risk factors, but there's a lot more work that needs to be done with regards to diet and other risk factors for the development of the condition and its complications. Looking at non-operative management of patients with complicated diverticular disease, we undertook a study that's funded by Guts UK using routinely collected data, which was published in the British Journal of Surgery Open 3 years ago now. And what we did was we looked at all patients who were admitted with perforated diverticular disease, and we then followed them up to see whether they'd developed particular or had a risk of developing complications following treatment with antibiotics alone. And what we found was that the majority of patients following their first admission who were treated with antibiotics never required surgery after that first admission, although they did have an increased risk of being readmitted to hospital, about a 28% chance of coming back in, but they were treated with antibiotics again and avoided surgery, and therefore the need potentially for a stoma. There's also a series of studies that looked at laparoscopic lavage, so rather than cutting out the piece of bowel that was affected by the complicated diverticular disease, whether we wash that area out and place a drain was more effective and avoided a stoma. And there were 3 studies from Scandinavia largely that looked at this. And what they found was that there was a reduction in the risk of getting a stoma by using this technique. The problem was that a large number of patients had unplanned hospital admissions and required re-intervention after their first operation. And that was felt to be something that needed to be really well explained to the patient before they underwent surgery. So they knew that there was an increased risk of actually having another emergency operation should this fail. So in the NICE guidance, we've put together a decision-making tool to help patients and surgeons make that choice. Although the majority of patients looking at the UK data still undergo Hartmann's procedure, which forms a stoma. There is some evidence that you can join patients with acute diverticulitis and its complications back together and avoid a stoma. And this study, the LADY study, randomized 133 patients into a group who had a primary anastomosis, which is a primary joint of the bowel rather than a stoma. And it identified that those patients who are less than 85 were hemodynamically stable, could have a join rather than a stoma. So all of this evidence led us to the NICE guidance in 2019, and we were able to publish for the first time some evidence-based guidance for the treatment of diverticular disease. but we highlighted within this a number of research questions that needed to be answered, and that there was a deficiency in our understanding of the condition. So some future work that's currently being undertaken. So Bowel Research UK have funded Dale Valmachandran from Chester to undertake a study looking at the management of acute diverticulitis globally. It started in the pandemic, which was an incredibly difficult time to start a study, but he's now got data and collected data on just over 6,000 patients treated at 250 hospitals in 48 countries across the world. The first manuscript from this should be published soon, and it's important, this work, because it shows the variations in treatment for the same condition across the world, and documents the outcomes for those patients. So it should give us an insight into what the best treatments or the best approaches might be in this group of patients, and also to allow us to standardize treatment globally. And then one area I'm particularly keen on, if you already heard about today, is the Diverticular Disease Priority Setting Partnership. This is this joint venture with Guts UK and Bowel Research UK between patients and researchers. And hopefully this is going to identify the important questions that need to be answered. And it will also unlock funding for researchers to undertake the research that needs to be done in response to that. So thank you very much. I'll stop there.
Thank you, Mr. Humes. I think we are running a little behind. We do have quite a few questions in the question and answer box. And thank you. I noticed you have answered some of those already, Mr. Humes, and hopefully we can answer some of those whilst the other talks go ahead. There's lots of thanks to Linda for sharing her story. I do have a question for you, Linda. What's it like being both a patient and a healthcare professional, and do you find it a help or a hindrance?
Interesting question. I think I'm also a nurse specialist as well by background, so I've sort of been in that unique role of supporting patients with complex diseases as well. I think personally for me, I think it's beneficial. It may not be beneficial for the people who look after me, because I'm quite nosy and I want to know what's going on. So it's a double-edged sword, really. I think part of it's helpful and part of it can be a bit tricky as well. But I think it's, for me personally, it's helpful to have a medical understanding of what I'm dealing with.
Thank you. And one for Mr. Humes, I think. Are there any mandated, just bear with me, NHS offerings of screenings of these types of bowel diseases along any age group, or are most of these cases found incidentally or following an acute episode?
So most are found incidentally being investigated for another condition. So the only screening program we have currently for bowel-related conditions in the UK is the bowel cancer screening program, which will obviously open to the age range 55 to 73, hopefully shortly. But they will find diverticular disease as part of that. But there's no other mandated screening program.
Thank you. And maybe just one more. Is there any evidence of a hereditary link for diverticular disease? Where does looking at medical history sit within NHS systems currently?
Yeah, so there is some evidence from twin studies from Denmark that there's a link or a hereditary link, but we haven't identified individual genes that predispose to that. It's probably multifactorial, related to environmental factors around the diet, toileting, and it's a combination of those factors rather than just one. There are some specific. There is a question about Ehlers-Danlos syndrome. There are some people who have collagen disorders, which Ehlers-Danlos is one of them, who may be predisposed to developing diverticular disease.
No, thank you so much. And I'd like to thank all the speakers today. That was an absolutely fantastic session. I'd like to now hand back to Sam for the next session. Thank you so much.
Thank you very much, everybody. Just as a reminder, our third and final session today will be at 3:25 and is on surgical and interventional science, including robotic surgery and research into fecal incontinence. So please do join us for that too. But right now we're going to move on to the gut microbiome session, which is facilitated by patient advocate Stephen Rowley. So Steve, I'll hand over to you. You're muted, Steve.
There we go. Am I there now?
Yes, you're there.
Thank you very much, Sam. My name is Stephen Rowley, and I'm a patient advocate in the West Country, working in research and with the NHS, and also on the Patient Advisory Committee of Digestive Cancers Europe. I am delighted to be facilitating this session. In 2015, I was diagnosed with stage 3 colon cancer, followed by surgery and chemotherapy. But 3 years later, my brother Damon was diagnosed stage 4, and he died within 6 months. At the beginning of COVID, I set up a bowel cancer support group online, Bowel Cancer Support Group UK, which has now got more than 5,000 members. Diet and nutrition is one of the common topics of discussion amongst our support group. People often feel that their diet must have caused their cancer, and also that by changing diet, they might cure the cancer or at least aid the hospital treatment. In recent years, gut microbiome has firmly become part of the national discourse about nutrition and diets. And we also know that bowel cancer can be associated with microbiome changes. In this session, we will hear from 3 speakers. Firstly, Anne Skennerton, who, like me, is someone with lived bowel cancer experience and an inquisitive mind. She will be followed by 2 experts in the field of microbiomes. Firstly, Professor Simon Carding of East Anglia, I think University of East Anglia, and then Dr. James Kinross, Imperial College. And I'm sure that all 3 speakers will raise questions in your mind. We will have a few minutes at the end of the session for Q&A, so please use the Q&A feature at the bottom of the screen to pop in your questions at any time, and we'll pick them up and read them out. So firstly, Anne Skennerton. She is happily retired from a full-on professional career in education. She now lives on the south coast of England and enjoys working in the large garden, gig rowing and walking with ramblers, and playing duplicate bridge. Occasionally, she's lucky enough to spend time with her 2 married adult children and their grandchildren. So over to you, Anne.
Hello. I'm speaking as a non-medical layperson who has had her own bowel cancer discovered 10 months ago and witnessed the consequences of her mother's bowel cancer during 1969 to 70s when I was about 19. I'm unsure what light I can shed on the gut biome aspect, so I'll do my best to make a useful connection. Let's start with my cancer diagnosis and the surgery I opted for on December 29th, 2023. This includes the preliminary medical check, which, in my opinion, is extremely important for medical staff to appreciate. Without it, my cancer would have been diagnosed much later, if at all. In mid-October 2023, I was lucky to have a youngish locum call me in after my brief online summary of recent intermittent pains in my lower abdomen, which I privately suspected was a bladder infection, so was hoping for just a urine check. She checked, suspected possible infection, so issued a 3-day antibiotic. I took the opportunity to ask why my blood hemoglobin level had been, in August, declared normal, when it was, in my opinion, on the low side. From memory, maybe 11.8. She checked and said, "I wonder where the blood is going." In spring 2024, my GP later told me that the usual GP view was that it was normal and they'd be looking for anemia before referring me for an FIT test. I was lucky to have a medic who asked the question and then gave me a bowel FIT, which, unlike the usual 2-yearly one that I routinely have been taking since retirement, would go, she said, to our hospital as more thorough. I dropped off the FIT the Thursday, and I was rung by Queen Alexandra Hospital the Monday for a 14-day, inverted commas, screening stroke scan. I wasn't worried, as for me, I had nothing obvious going on except for an extra number 2, that's a poo, mornings beyond my clockwork, post-breakfast, unproblematic poo. There was never any obvious red in my poos, red blood in my poos. I always check for personal hygiene purposes, so it was the hemoglobin that isn't red. Like that which showed up in my urine test in 2017 that subsequently led to a camera investigation and, most unexpectedly, a stage 1 non-invasive cancer, which was removed in day surgery. The bowel scan plus eventual colorectal endoscopy discovered both a 3-millimeter polyp, removed by the endoscopist at the time, and an apparently more problematic 32-millimeter polyp in the ascending colon, with biopsies later revealing stage 2 colorectal adenocarcinoma. Treatment: robotic right hemicolectomy, which subsequently included 22 swollen, so the surgeons later told me, lymph nodes. Mid-January of 2024 gave the welcome news that there was no sign of the cancer having spread. You might have read in my requested biography, no, you wouldn't have done, sorry, I had to change it. I have familial cancers, which appear to have been identified in those members of family from ages 50s to 60s, eventually proving terminal after some years. So briefly, my mother's mother had a brain tumor, which went on for about 17 years in the days when they didn't operate. My mother had bowel cancer, which she somewhat neglected and later became a colostomy, but she survived her surgery by 19 years, having had also that therapy. My father started with skin cancer, went on to blood cancer, and then eventually had about 4 brain tumors, etc. So I was rather hoping to dodge the bullet. My sister died at the age I am, younger than the age I am now, with Hodgkin's lymphoma, I think. And now I have a brother 3 years older than I am who apparently has blood cancer, but he's alive in his 70s. So in response to my question, my colorectal surgeon told me in the February post-surgical checkup that if my cancer was hereditary, which I have always wondered, I'd have suffered from it as a younger person. I'm 73 this month. He told me that the diverticulosis found in my bowel/gut was probably laid down in childhood and the result of a Western diet. On that note, I can state that my childhood diet was standard family fare of the meat and 2 veg, plus puddings, bread and milk, readily available for a service family on a limited income living in post-war England. When most of us later moved to central Canada, both parents worked till 6 at night. My memory was of the standard freezer meat, frozen or canned vegetable, with limited fresh food in a city 6 months in sub-zero winters. My parents had neither energy nor interest in discovering new foods. In my teens, I became aware of health issues, both for me, and my dog, incidentally, so I took steps in those days without the internet to find out how I could help my body get better. I remember using a Yoga for Modern Living paperback for such ideas. Of course, I couldn't change the basic menus, though I did prepare family meals of the staple foods to help my mother through the week. I moved out of the home at 18 when I discovered and ate more varied foods. And that's remained with me through my life. So whole foods, organic when possible, whole grain cereals, no added sugar, pulses, fresh fruit, varied vegetables daily, minimal cooking, vegetarian a few times a week, grilled fish, roasted chicken, no skin, no gravy, rarely beef, and until the bowel cancer, low-fat dairy wherever possible. I rarely drink alcohol, and only a glass or 2 then. It neither interests nor relaxes me. Nor do I drink soda drinks, as I dislike their sweetness. On the social habits theme, I've never smoked, though my mother did, and I hated the smell throughout my life. Daily, I enjoy herbal and normal teas, ground coffee. Desserts are occasional and usually reduced sugar and homemade. We rarely eat out. It's cheaper and better to eat at home. Also, I enjoy natural yogurt daily. For several years before my bowel cancer diagnosis, I made my own kefir, though I don't now. I still grow our own fruit and some vegetables through the year, have done for the past 9 years. Never used any pesticides, in a large garden with a natural pond, so we have plenty of bird life and insects. So I asked myself how I managed to grow a bowel cancer. To refer explicitly to the umbrella topic for my contribution today, the gut biome is, as I read online, the collection of all the genetic material from the microbes in your gut. It contains around 3 million genes. Gut microbes digest fiber from your food, shape your immune system, and help protect you from pathogens. Your diet is a key factor in determining which microbes are in your gut. That was April 2024, the National Institute of Environmental Health Sciences. If this is true, then how do we address a situation such as mine? It sounds like the genetic material is from my gut's microbes, which, after decades of healthy eating and exercising, keeping fit, should surely have sloughed off the inadequacies of my younger upbringing, poor diet and lifestyle. The only fitness then being at school or bike riding. Or did the dietary intake during those younger years so adversely affect my growing gut that I'm just lucky to have lived this long and well? I actually feel profoundly lucky in having had a younger locum ask the very question I had earlier asked and was not followed up by my otherwise worthy medical practice. One further point that might be significant is that I have lived a very stressful life. Work-wise, I'm a workaholic, and many lengthy periods of several traumatic personal stroke family life, which started at a young age and have intermittently affected me now throughout my life. I am aware that the gut is for some viewed as the third brain of the body, and that one's immune system can be adversely affected by one's mental, emotional, and physical stresses and strains. I fear that those elements in my own life may have mitigated against all my well-intentioned, otherwise healthy choices as an adult. Thank you for listening.
Right, thank you so much, Anne, and thank you for sharing your story. And certainly in my bowel cancer community, there would be many people who would identify with the issues and the topics you raise. Which is a reminder that we have a Q&A feature at the bottom of the screen for people who have any questions for the end of the session. So next we are moving on to Professor Simon Carding, Head of Food, Microbiome and Health Research Programme at the Quadram Institute Bioscience and Professor of Mucosal Immunology at Norwich Medical School, University of East Anglia. Professor Carding completed postgraduate work at the Medical Research Council's Clinical Research Centre in Harrow. He then undertook postdoctoral work in the USA at New York University Medical Center and Yale University School of Medicine prior to a faculty position at the University of Pennsylvania. He then returned to the UK and the University of Leeds to develop a program of research focusing on commensal gut bacteria in health and disease. And now at the Quadram Institute and the University of East Anglia in Norwich, he leads a large multidisciplinary food, microbiome and health research program. They're unpicking the complex relationship between plant-based foods, the gut microbiome and human health. The focus of Professor Carding's own research group is understanding how the gut microbiome and its bacterial, viral and fungal constituents interact with each other and their hosts. So Professor Simon Carding, over to you.
Thank you very much, Steve. And thanks to Anne, who's given a very nice précis of what I'm about to do in 15 minutes. So I have control of the slides, excellent, right. So my task here is to introduce to you gut microbes. That's it. Excellent. We're going a bit too fast. So I thought I would introduce sort of the importance of gut microbes, what they are, what they're made up of, what they do, and how they can promote health and in some cases cause disease. And my slide here just gives you some basic facts and figures which may be of interest to you. So every external and internal surface of our body is coated with microbes, which collectively we call the human microbiome. And they comprise between 10 and 100 trillion cells, which outnumbers our own cells in our body by about a factor of 10. And it's a rich, complex mixture of microbes that inhabit our body. And just regarding the bacteria alone, there are maybe more than 10,000 different types of bacteria that live on or inside of our body. And all of these microbes, as Anne has mentioned, have their own DNA content. And if we take that as a proportion of the DNA in our cells, that makes up 99% of the DNA that we carry around with us. So most of us is actually microbial in origin. And this vast amount of DNA encodes, as Anne has mentioned already, over 3 million genes. which is in stark contrast to the 22,000 genes that are encoded in our own genome. Another interesting fact is that our microbiomes are unique to us, and in fact, less than 1% of us share the same microbiome. So we have a unique microbial fingerprint, and that contrasts with our genome, in which is identical in 99.9% of us. So we have a microbial uniqueness and signature, which is important when we're considering health and disease and how we can promote disease, promote health and prevent disease. The largest number of microbes in the body are contained in the gut, and this is called the gut microbiome. And it's important to know that it's not just bacteria that make up our microbiome. So there are viruses, and these can be equal, if not more in number than bacteria, yet we have a very poor understanding of the virome in the gut. There are also fungi, including yeast. Some of those are derived from the food we eat. We then have archaea, which we call our ancient microbes, and these are primarily methane producers. And then we have protozoa as well. And if we include the food we eat, the plant material we eat, we actually have all kingdoms of life represented in our gut at any one time. As was already mentioned, the gut microbes are essential for our health. They process and digest the food that we eat, particularly the plant-based food, to extract nutrients we can use. They're also an important source of vitamins and enzymes that allow us to keep the cell healthy as well. And they also play an important role in keeping the immune system functional and efficient to help us protect against infections and disease. So maintaining a healthy gut micropopulation is a balancing act, and there are various factors which can promote a healthy gut microbiome and in turn the health of our body. These are shown on this slide. So what happens in maternal early life is very important. Levels of activity, our lifestyle, our genes, and the diet. On the other side of the balance, there are things which can tip it towards a disturbance in gut micropopulations, which we call dysbiosis. And this often precedes or is associated with lots of different diseases. So you can see as we age, we lose certain populations of microbes, where we live, how we live, stress, lifestyle, infections in particular, and antimicrobials, antibiotics. These can all push this into dysbiosis and a disease setting. Not surprisingly, most, if not all, human diseases now have been associated with dysbiosis or changes in the makeup of our gut microbes. And this actually goes all the way back to Hippocrates, the father of modern medicine, who said in 460 BC, all diseases originate in the gut. And perhaps there is some truth in that. But as you can see on this slide, lots of organ systems and the disease associated with them can be associated with changes in gut micropopulations. So obviously there's been an intense interest in trying to identify which microbes in our gut microbiome are responsible for this. So this is a little bit like searching for Waldo. So here we have a slide, and maybe I'll just give you a few seconds to try and identify Waldo, but this is the sort of situation we're faced with in trying to identify amongst all these 10,000 or more species, the single one that may or may not cause the disease. So here is Waldo. The problem is that there can be many Waldos, either openly or in disguise, which on the right conditions can cause disease. So it's a very difficult problem to address in terms of identifying the actual microbes that are causing disease. And in truth, it's probably a combination of lots of different microbes changing their behavior to cause disease, and it's probably not one single microbe. We also now know that what happens in our gut can influence our brain and behavior. And this cartoon here depicts some experiments that were done to really illustrate this in mice. So we have mice that we can raise under germ-free conditions, so they're entirely sterile. These animals display deficiencies in learning, memory, and social behavior. If the animals are taken out of these conditions and exposed to microbes in the environment, then these deficiencies can be overcome. So there's a direct link to microbes, our human microbiome, and how it influences our brain development and behavior. And increasingly, we now appreciate that our gut microbes can influence mood, memory, sleep, reward, pleasure, and compulsion. And the downside of this, there's also evidence they're linked to perhaps depression, some neurodegenerative diseases and dementias like Parkinson's disease. They're also linked to controlling hunger, satiety, and again, the flip side of this is that can be linked also to malnutrition and obesity. And then sweetness and taste preferences. So the gut microbes can influence what we eat in terms of influencing our food preferences. This again can be related to diabetes, obesity, food allergies, and even perhaps some of our sweet tooth obsessions and chocoholics as well. So gut microbes can influence lots of things in the way that we behave, and we are also disease affecting the brain. So using microbes to change mental health is not necessarily new. This slide here illustrates an experiment that was carried out in Bethlehem Institution in London, treatment of melancholia, using a lactic acid bacillus, which is present in sour milk. And Dr. Phillips gave this to 18 patients suffering from melancholia for breakfast and supper. And after 5 to 6 weeks, 11 of the 18 patients were cured. We now know that this curative effect was related to the presence of a neurotransmitter that these bacteria were able to produce. This neurotransmitter is called GABA, gamma-aminobutyric acid. And this is an interesting neurotransmitter because it acts on receptors to calm down the nervous system. So targeting the receptors is an important aspect of how sedatives, muscle relaxants, and anesthetics work. And so some of the claims for take a probiotic formulation to help you relax and reduce stress are in fact related to whether or not the microbes in these probiotic concoctions or formulas contain GABA or producing GABA. We also now know that gut bacteria can produce lots of different types of neurotransmitters, so almost acting like a second brain, if you like. And this includes dopamine, serotonin, and histamine. So there are direct links now in terms of being able to manipulate gut microbes to produce more dopamine, more serotonin in patients who have deficiencies of these, including Parkinson's disease, for example. So how do we treat an abnormal gut microbiota? So I've made a comparison here between lawn care. And so in the top left-hand corner here, we have a flourishing gut ecosystem. We can put down weed killers, which would be analogous to antibiotics, in the hope of killing weeds, but obviously there can be collateral damage to this. And left alone, then the weed species can run wild, and that represents dysbiosis. So the approaches we can take are drugs, probiotics, prebiotics, and the more radical, which is lawn replacement or bacteria therapy. So a little bit about each. First of all, antibiotics. Whereas they can be quite effective in treating some bacterial infections, they can also be an adversarial component of particularly impacting on the gut health of the gut microbiota. And in fact, we are probably taking far too many antibiotics, as I'm trying to illustrate on this slide. Interestingly, most of the antibiotic use occurs in the meat industry to check infections and accelerate animal growth. Consequence of this is we get environmental contamination. Our rivers, soil, etc., become contaminated with this, and this can get transferred to us as we eat or consume products that come from this. In 2019 and 2020, there were 30 million antibiotic prescriptions in the UK. Almost half of these were children under the age of 4 years of age. Fortunately, though, we're now seeing a slight decline in this as we become more aware of the consequence of overprescribing antibiotics. And in the US, the Center for Disease Control estimates that 47 million antibiotic courses are not required to treat particular conditions. So there is still a massive overprescription of this. A consequence of taking lots of courses of antibiotics is that the collateral damage to the healthy gut microbes. It drives the development of drug resistance in some microbes, and it can allow the outgrowth of some potentially very dangerous bacteria, such as Clostridium difficile. Antimicrobial resistance, as you may know, is a significant issue in medicine at the moment, and the number of deaths is likely to increase significantly over the coming years to as maybe as 10 million deaths caused by the inability to treat infections because we've potentially run out of antibiotics because the microbes have acquired resistance to all the drugs. And this comes at a tremendous cost. So we need alternative ways to address our dysbiotic gut microbiota. The probiotics is one approach that I've already mentioned, and this probiotic refers to live microorganisms. When administered in adequate amounts, will confer a health benefit. The individual I'm showing here on the left, Eli Mechnikov, is the father of probiotics. He received a Nobel Prize for his discovery. And this arose from an observation he made in Bulgarian and Russian peasants, in particular those that were exceptionally long-lived. They seem to subsist almost entirely on fermented milk. And this led to him developing the first probiotic, which is essentially sour milk, which Dr. Phillips used successfully at Bethlehem Hospital to treat his melancholia patient. There are now a plethora of probiotic formulations for adults, for children, even for pets. And not surprisingly, it's a very lucrative business for the probiotic manufacturers. So the projected global market for this is estimated to get to 73 billion by 2027. Not unsurprisingly, lots of health claims have been associated with particular probiotics. However, the European Food Safety Authority has rejected most, if not all, of the probiotic claims that have been made to cover healthy gut flora, decreased digestive transit time, immune system boosting, defense against pathogens. And the reasons why these health claims have been rejected are illustrated here. Food is not sufficiently characterized, not enough evidence, insufficient evidence to establish a cause and effect. So this has led to a toning down of the health benefits that we put on labels on probiotic products. Prebiotics, this can be considered as food for bugs. They are essentially different types of sugars, inulin, for example, polydextrose, lactulose, etc. These are naturally occurring sugars found in breast milk. For example, inulin is found in breast milk. Whole grains, fruit, and vegetables contain lots of these. The daily recommendation for consumption of probiotics is 4 to 8 grams for general digestive health, or approximately twice that level for digestive disorders. The best sources of this that I've illustrated here on this table, so gum arabic, which comes from the acacia tree, which is shown here. So consuming 7 grams of that will essentially give you your daily serving of prebiotics. The chicory root, an artichoke, 10 garlic cloves, all the way down to 4 to 5 bananas. Unfortunately, there's only a very small proportion of the population that actually manage to achieve this on a sustainable daily basis. Some estimates say it's 2 to 25% of the general population. So there is this general insufficiency, if you like, of consuming sufficient probiotic foods to improve or keep your gut microbes healthy. So in terms of the best foods to keep your gut bacteria healthy, that is not surprisingly 5 servings of fruit and vegetables a day, which the government has been pushing for a very long time. But then there are the superfoods, which are the fermented foods, which give you the benefit of having a prebiotic in terms of the vegetable or the fruit, and the prebiotic in form of the bacteria, which are fermenting the food. So you get the benefits of both probiotics and prebiotics in fermented foods, which is associated with their superfood label and ideal ingredient to be taken to improve your gut microbiota. So that leaves the more drastic option of replacing your diseased lawn with a new lawn. In the context of gut microbe therapy, this is called fecal microbiota transplantation, or FMT, or microbiota replacement therapy. Now, this has been used very effectively in the NHS for treating hard to treat Clostridium difficile infection. It's a hospital-acquired infection generally. The cure rate is phenomenal. It's over 90%. And it's far more cost effective to have the FMT than course after course of antibiotics to try and eliminate the bacteria. And it is now an NHS frontline treatment for this particular difficult to treat form of Clostridium difficile infection. FMT is not new. It's first reported in Chinese medicine in the 4th century, when a fecal suspension was delivered by mouth for treating diarrhea, food poisoning. Later on, it was developed into yellow dragon soup, and this was used to treat a whole variety of different diseases, including constipation, abdominal pain, etc. Veterinarians have been using FMT, or as they call it, transformation, since the 17th century to promote the health or treat animals with digestive conditions. And then during the Second World War, German soldiers would consume camel poop soup to protect them from dysentery. German doctors subsequently identified one of the key microbes present in the camel poop soup, which was called Bacillus subtilis. And this led to the formulation of a product which can still be bound as a medication that can still be purchased, called Bactisubtil. And that originates from this experiment done in the 1940s during the Second World War. The first human trials for FMT started around 1957, where surgical patients were given their own encapsulated feces post-operatively to improve recovery from surgery. And then a little bit later, fecal enemas were used to cure patients with enterocolitis. And then in Australia, they've been used since the late 1980s to treat a variety of GI-related conditions, including inflammatory bowel disease, ulcerative colitis. And then the real breakthrough in terms of NHS practice came around 2013, when a Dutch group showed that they could use FMT to treat and cure patients with C. difficile infection. So we started with an oral suspension. We've gone through delivery, through enemas, jejunal tubes, colonoscopes, and now we're back to the oral route again, but this time most FMTs were looking at delivery via capsules. So in terms of the future, we're probably looking at personalized medicine in developing cocktails of microbes that could be encapsulated, that are unique to treating an individual, which can be used preemptively, particular stage of life, to protect against later adverse effect diseases, promote lifelong health. That's in the future, but it's probably realistically maybe only 10 years away before we're doing that. At the Quadram Institute, we have an FMT facility. We've been working with the Norfolk and Norwich University Hospital to prepare formulations. Originally, they were formulating syringes delivered by tubing, jejunal tubes. And so far, we've got a success rate of about over 90%, as other university settings and other FMT facilities have achieved. We've had to make the facility super clean in order to comply with MHRA, because FMT is considered a medicine, so it has to be prepared under super clean conditions. And we are in the process of developing protocols for 2 clinical trials, the first of which will happen next year in myalgic encephalomyelitis and chronic fatigue syndrome, and later in Parkinson's disease. In terms of, so this is what we call our capsules. This is how we'll be delivering our FMT in these clinical trials. So the potential applications are, I think you can appreciate, are numerous: metabolic disorders, obesity, eating disorders, autoimmune diseases, including inflammatory bowel disease and rheumatoid arthritis, and interestingly, aging and cognitive immunosenescence and cognitive decline. So I have a little video here that runs for about 90 seconds, which illustrates the potential benefits of FMT in improving aging, aspects of aging, and this was carried out in animals. So that's work continuing in my group, and I'm just leaving you now with my take-home message, which I won't read out. You can read that at your leisure. Thank you, and I'm happy to take any questions that you may have.
Sorry, my microphone stopped there. Thank you so much, Simon. We'll be taking questions at the end of the three talks, so we'll be looking at that. But I found that fascinating. Clearly, the gut microbiome is an area of exploration and emerging opportunity for diagnosis and treatment. And I was particularly interested in the Russian origins of the probiotic research. When staying with families in Russia, I found fermented foods were the norm, and we consumed more smetana, which is like a sour cream, than milk. I'm quite looking forward to the prospect of dopamine-inducing yogurt on my muesli in the morning. Now we come to Dr. James Kinross, Reader in Surgery at Imperial College. James is a senior lecturer in colorectal surgery and consultant surgeon at Imperial College London. His clinical interest is minimally invasive and robotic surgery for colorectal cancer. He is visiting professor of the Royal College of Surgeons in Ireland and performs translational research into a diverse set of research themes, such as digital surgery, robotics, computational and systems biology in surgery, and the gut microbiome. He leads a mixed reality research group pioneering applications in surgical education and direct clinical care. He is co-founder of the cognitive surgery company Medicalisite, and I might add, though not listed in his short biography that he gave me, he is the author of a fascinating book entitled Dark Matter, all about the different microbiomes that we share our bodies with. So, James, it's over to you with do bacteria in the bowel cause cancer?
Thank you for such a warm introduction, and thank you to Simon for setting the scene so brilliantly, and to Anne for raising some of the themes that I hope we're going to talk about over the next 15 or 20 minutes. So look, thank you everybody. It's a tremendous honor to be with you. Just amazingly insightful talks today, and I've certainly learned a lot. So I am a colorectal surgeon. That's what I do by day, but my group does a lot of microbiome science work, and a lot of the work we do is trying to understand how bacteria particularly, but also other microbes in the gut cause cancer, and how we're going to engineer them. And what I'm going to try and do today in this talk is answer some of the questions that Anne raised in her initial presentation. So I do have some disclosures of note. I do help a company called Intersbio, which is developing microbiome-based diagnostics. And this is what we're going to talk about. So Professor Cunning's brilliantly given us an insight and overview of the microbiome. So I'm not going to spend much time talking about that. But by the end of this talk, what I want you to understand is that the microbiome is dynamic. It changes with us over life. And when you're trying to understand a disease like cancer and causation of cancer, you've got to understand the microbiome within that context. And of course, causation is complex and multifactorial. And it's probably not quite as easy as one bug causing cancer, like a sort of Rosetta Stone type model. It's multifactorial, obviously, by definition. But nonetheless, the microbiome, if it gives us one gift, its major gift is in the prevention of disease. And that's really what I'm going to focus on, because I firmly believe that we can prevent bowel cancer by understanding much more about the microbiome. So I put this picture up every time I'm talking, mainly to embarrass Georgia, but it's also to do two other things. One is to say that we have a microbiome call open with BR UK, which is generously funded by the BR UK community, and we are extremely grateful for that funding, and we're really excited about the work that we're going to fund. And this was the microbiome garden that we were lucky enough to host this year at the Chelsea Flower Show. We won a gold medal. I say we, it definitely wasn't we, it was definitely the BR UK team. And this makes a really key point, which is that a fundamental tenet of microbiome science is that it connects us both literally and figuratively to our environment. So obviously the gut is a giant sensing organ. What goes through it has a direct impact on our health. But the soil microbiome, of course, is very, very important in its own right. And we have co-evolved with microbes. And that is a key message, because when the evolution, this evolutionary relationship that we have with our microbes decays when it starts to fail. I'm arguing that that's why we have a changing burden of chronic disease. So if you look at adjusted disease-associated life years over the last 100 years, that the burden of disease is fundamentally changing. Cancer wasn't a problem maybe 100 years ago because you were likely to die from a pathogen. You weren't likely to live long enough to get cancer. But now, of course, it's a major burden of disease globally. And diseases that we typically think have nothing to do with bacteria, like cardiovascular disease or obesity or some of the mental health disorders that Simon was alluding to, we think now are actually associated with microbes, but they're not associated in the same way that we traditionally think about infections or pathogens. I'm arguing that it's the loss of really important bacteria that within us that we call mutualists or symbionts that seems to be an important and common theme. And bowel cancer epidemiology is changing, and it's changing really, really dramatically. So if you're born in the 1990s, you have double the risk of bowel cancer than someone born in the 1960s and 70s, and 4 times the risk of rectal cancer. That cannot be explained by human genetics. It has to be an environmental driver. And the question we're asking in our research group is, what role do microbes have within this? In the next 15 or 20 minutes, I'm going to outline a case that actually bacteria are extremely important in explaining this dynamic risk. So I'm not going to go into the microbiome because Simon's done that so nicely, but I just want to start by showing you this one slide. This is something called 16S ribosomal RNA data. So this is, if you like, a gene sequencing attempt to look at the microbiomes of about 170 of my patients who have bowel cancer. And we've actually sequenced the tissue of the bowel cancer, and we've sequenced the microbes that are on that tissue. And then we're looking at the broadest phylogenetic descriptions of these bugs. So what I mean by that, the biggest families, if you like, of those bugs. So we're not really interested in species, we're looking at broad family descriptors. And what you see in that bar chart is that about 4 or 5 big families of bugs exist on these cancers. And the only takeaway that I want you to take away from that slide is that it's hugely variable. So each little bar is a patient, and you can see that some have absolutely no firmicutes and some are completely dominated by firmicutes. And we don't really understand the importance of that variance. Like, what does that really mean, both in terms of the causation of cancer, but also in terms of treatment response and outcomes. And to understand that meaningfully, I'm going to argue in the next 15 minutes that really need to understand dynamic changes in microbes across life courses. And you also need to understand function. And the function is the really, really interesting and important bit. Now, what we like to try and do in science is to simplify things down to the most basic and fundamental elements, because if you can identify, for example, a single bacteria that causes cancer, well, then you can knock it out, you can destroy it, and of course, you can reduce cancer risk. But that's not quite really how biology works. Microbes exist in complex networks and communities. And there's another truism, which is that no matter how many good bugs you have, if you don't treat them well, then they are not going to behave well. And therefore, the consequence might be not so good for you or for me. So I take this quote often from Goodfellas, a Martin Scorsese classic. I use this slide all the time because it's just so true. And in this film, Henry Hill is talking about what it's like to be in the mafia, and he's talking about, you know, the relationship that he has, and he says, "See, your murderers come with smiles. They come as your friends, the people you've cared for all of your life, and they always seem to come at a time that you're weakest and you're most in need of your help." And they could be describing various aspects of the microbiome. In this case, H. pylori. So H. pylori is a bacteria that exists in the gastric stomach, and this has now been officially designated as an oncogenic bacteria. We know that if you eradicate this bacteria, that you significantly reduce the rates of gastric cancer, and its relationship with gastric cancer is extremely important. And the side effect of this is that H. pylori has been really labeled as a bogeyman. It's a bad bacteria. And in fact, there is now a global attempt to really eradicate H. pylori. The problem is that H. pylori isn't a pathogen. It might cause cancer if you treat it badly or you don't create the right environment for it. But eradicating what is in effect a symbiont, a mutualist, a microbe that actually we've co-evolved with, might have unintended consequences. So what we know is that this is actually Otzi. He's a Bronze Age man that was dug up in Italy. We've been able to sequence his microbes, and we know that H. pylori was in his gut. It's been there really since the dawn of man. And when you start using very large amounts of antibiotics to eradicate just one bacteria, you have a knock-on effect on all of these other important bacteria that maintain and optimize our health. And what we're seeing in population-wide studies that have been big exposures to these antibiotics is changes in the risks of other diseases which we don't want, like asthma, for example. So large-scale use of antibiotics to treat pathogens may not be a good solution. Now, this is an image taken from a dental plaque, and it's a particular type of imaging that allows us to see particular types of bacteria that might exist within a network or a colony. And what you can see within that is lots of different types of genus of bacteria. And you can see that it's like a bloom. It's like this super complex network, and there are lots of little niches. So actually, we have microbiomes throughout our body, and our oral microbiome seems to be extremely important. And I'm telling you this because a large number of bacteria that we find in cancer, and in particular bowel cancer, seem to originate in the mouth. And the best example we have of this is a particular bacterium called Fusobacterium nucleatum. And there's a lot of interest in how Fusobacterium nucleatum causes cancer. Now, what we know is that Fusobacterium nucleatum turns up in lots of different types of cancer. It doesn't just turn up in bowel cancer. In fact, it even turns up in cancers like breast cancer, but certainly throughout the gastrointestinal tract. And there's an argument as to whether or not Fusobacterium nucleatum is a driver of cancer, whether it really causes cancer, or whether indeed it's a pathogen, a bystander, a passenger. And we have another large number of different sort of actors that we think are probably quite important in the cancer story that might also be cancer drivers under specific circumstances. So E. coli, for example, in patients who have ulcerative colitis. What's particularly interesting is that patients who have cancer seem to create a slightly different condition, which allows a secondary niche to grow within those cancers. So trying to study cancer after it's occurred is really very difficult from a microbiome perspective. What's quite important, though, is that there seems to be a moment, a point, that changes the relationship of the gut to the mouth, which allows these particular bacteria like Fusobacterium nucleatum to suddenly colonize the gut in a way that they probably shouldn't under conditions of health. And we're beginning to see that now with Fusobacterium nucleatum. So there was an important study that was published very recently that showed that actually very, very specific subclades of this particular bacterium, Fusobacterium nucleatum, reach a tipping point where they can suddenly grow within the gut. And if you can identify that tipping point, then actually the oral microbiome becomes quite an important way for screening and maybe even detecting the presence of bowel cancer. But it also means that the precision that you need in measuring those particular types of bugs, that very, very specific subclade of F. nucleatum, in this case, F. nucleatum animalium, is really, really important. So a lot of the tests that we currently have for doing that are commonly used in consumer tests of the microbiome don't really work. They're not really adequate. They don't get that level of absolute precision that you need. Now, work that we did funded by Bowel Research UK, this was done by my PhD student, James Alexander, who's now a consultant gastroenterologist at St. Mark's, showed another thing that we think is quite important. So what we did was we looked at 127 patients that came from both the UK and the Czech Republic. And we looked at not just patients with bowel cancer, we looked at patients that had polyps as well as a cancer. And what we were able to see is that the progression from polyp to cancer is not just about the overgrowth of perhaps bugs that might cause cancer. You can see that in this little bar chart here, because we saw these little cluster changes. It's also about the loss of symbionts. So it's as much about the ecosystem that is absent as it is about the bad bugs that drive cancer. What this slide also shows is that you can also make predictions about survival, not just based on whether a bad bug is there or not, but also whether it's absent. And in fact, the predictions that we were able to make about 5-year survival from bowel cancer were more accurate than traditional staging measures that we typically use in bowel cancer. So we think that these bacteria have a very important and very sophisticated relationship with the genetics of these cancers and the biology of these cancers, and probably also in the particular chemotherapies that we use. But that's a different talk for a different day because we've only got 15 minutes.
2 minutes left there, James.
2 minutes. Okay, fine. All right. So to understand then why this might be important, then you also need to understand these time-dependent changes that I was telling you about. And bugs have lots of different pathways, and we often talk about them presenting as an orchestra because they produce lots of different molecules. And what we know is that mums who are pregnant, who are obese, have infants that have a different risk of bowel cancer. And what we understand is that this orchestral signaling of the maternal microbiome to the gestating infant is also really important in defining this risk at a later point in that infant's life. And diet-bug interactions define this risk from the minute you're born. It's not when you're munching on hamburgers in your 30s and 40s and 50s. It's how you're breastfed in very early life. And the breastfeeding, for example, is a critical determinant in the evolution of the microbiome as you're fed. It doesn't mean, though, that you can't change it when you get into later life. So in our group, we've studied African-American men who have very high rates of bowel cancer and rural Africans that have very low rates. When you Africanize an American diet, you change the microbiome, you reduce cancer risk. And we've known about this since the 1970s. What we just now understand is the mechanism. And the mechanism is in part defined by bugs. But it's also explaining why things like ultra-processed foods change cancer risk. And we now know from very good epidemiological data that they change cancer risk. And ultra-processed foods are also influenced by bacteria. Bacteria change how they cause, how they influence cancer risk. And we got some very good examples. So red 40, for example, we know is changed by bugs in the gut. But the major point I really want to make is I want to pick up on this notion that Simon picked up on, which is that antibiotics are a fundamental determinant of microbiome health. And we've known since the 1940s that when you take a chicken and you give it lots of antibiotics, it gets fatter faster. It changes the metabolic health of that animal. And the same thing happens in humans. So if you want to understand obesity epidemics, you have to understand how we use antibiotics. And if you want to understand changing cancer epidemiology, the same thing applies. So when we look at children who have grown up with longitudinal exposure to antibiotics. So in this particular study of Finnish children, the type of antibiotic is very important. The dose frequency of antibiotic is very important. But children who get lots of macrolide antibiotics in early life have an increased risk of asthma, type 2 diabetes, and also cancer risk. It changes their cancer risk. And we now know this again from very large scale epidemiological studies, that if you're having multiple doses of antibiotics in early life, your bowel cancer risk in later life changes. So if you want to understand microbiome and cancer interactions, you have to go back to the emerging and developing gut, and you have to understand diet, bug, antibiotic interactions. You can't simply study one in isolation. You've got to understand all of these three things, and we're beginning to do that. And so I'm coming to the final slide. So this basically summarizes really what I think is happening. So I think if you want to understand why you have a changing epidemiology of bowel cancer, you have to really understand genome, you have to understand genomic exposome microbiome interactions. The microbiome influences our cancer risk from the minute of conception, and it changes the minute you have a cancer diagnosis. What I'm arguing is that young people now have a fundamental loss and destruction in their gut ecology. In part, they're then getting a hyperglobalized, high-fat, low-fiber diet and exposure to multiple other environmental toxins, which the microbiome simply cannot process. The result of that is inflammation, and the result of that is bowel cancer. So if you really want to understand a disease like bowel cancer, you have to understand gene-environment microbiome interactions. And that means we need a new type of science. And a new type of science has to evolve from a science of germ theory to a science where we understand that actually microbial conservationism is a form of disease prevention in its own right. And that might mean nutrition and diet, and it might mean avoiding the use of antibiotics. So actually the way that I conceptualize this is we're experiencing an internal climate crisis. That's really what's happening. We're experiencing a catastrophic loss of our internal biodiversity, and the consequence of that is more bowel cancer. Thank you very much.
Well, thank you, James. That was most illuminating. And you raised, we're always being beaten about the global climate crisis, but an internal environmental crisis is clearly what you're proposing there. Thank you everybody, all the presenters, for their excellent and enlightening presentations. And I hope you're going now to be able to answer some of the questions, because we have got loads of questions have come in, and quite extraordinary. I think taking one here directly related to you, James, is, oh, it may also be to Simon. Is Simon still here? Cannot. Yeah. Do you want to come back on? So we've had a couple of people ask this question, Jane Aldridge and Wailing Butler. Does the preparation for colonoscopy significantly affect the microbiome? We've been talking about colonoscopies in all afternoon.
Yeah. So short answer, yes, it absolutely does. So you'll see it depends obviously how you prep the bowel, and different preparations have different impacts on the microbiome, but you basically see a 40,000-fold reduction in your microbiome. You have a massive cull in your microbiome. And many patients with IBS, for example, will report feeling better after they have their bowel cleansed. Often we think it's for that reason. What we know, though, is that the microbiome populations they'll bloom back, they'll blossom back. So usually within about 4 to 6 weeks, they'll return to their kind of pre-colonoscopy state. So that's the good news.
So you mentioned something there about IBS. Barbara Dowd asks, the gut microbiome, does it play a role in intestinal diseases such as IBD and IBS? Perhaps Simon can talk about that.
Well, I think the best evidence comes from animal models for a direct causality. In humans, of course, it's very difficult to know what comes first, the disease, changing gut microbes, or the other way around. But certainly they're a contributor to the disease, because any therapy that targets the gut microbes can lead to significant improvements. So they're definitely contributors. Are they the cause? Animal experiments would suggest they could be for maybe Crohn's disease and certain types of ulcerative colitis. But I think the jury's still out for patients, because obviously ethically we can't do the same experiments.
Right. Thinking about other diseases here, and this is about way we might use our diet to help with this. Steve Clark says, is there any evidence that taking fermented foods helps to treat disease or to help support enhanced treatments, such in cancer? And another one there, would you recommend all patients with Parkinson's to drink probiotics? And there's another one about dementia. Are there routes to using our diet to manage our gut microbiome to either influence the course of disease or prevent disease?
So what I'd say is that I think there are absolutely generic things that we can all do to improve the function and diversity of the gut microbiome through nutrition and diet. And I think that is true. And if you take one thing away from this talk, it's eat more fiber, eat more plant-based fibers. And yes, regular fermented food does change the diversity. But I think what we can also say to kind of Simon's talk is that the microbiome is massively individual. It's massively variable between people, and it's discrete and specific to you. And it's also specific and discrete between disease states. Now, you can use that to your advantage, right? If you have a measure of the microbiome and you have the measure of the biology, and I'll give you one example in cancer. So what we're beginning to see is that specific dietary interventions change the microbiome, which changes the immunology of a cancer, and that changes the way that cancer treatment works. So yes, you can absolutely use diet as a therapeutic target in its own right, but you can only do that if you've got a measure of the microbiome, and the precision with which we do that is slowly changing and improving. Like, it's still a relatively blunt science, so it's very difficult for me to say, yes, take this probiotic, you'll prevent your risk of Parkinson's. I don't think we can say that, but I think we can say nutrition, diet, generically is an important mediator of it.
Yeah, and I would just add that buying the probiotic formulations that you can get on supermarket shelves is not a good way to get your probiotics, because it's very expensive and there's an unknown amount of live organisms in each pot, and how many of those can actually get to your gut. Far better, far more effective means is prebiotic, fruit and vegetables. That's a better way of keeping your beneficial microbes happy for longer and offsetting outgrowths from the potential nasty bacteria you have. So spend your money on fruit and vegetables rather than Yakult pots.
Yes, I was looking at some of the other questions that are coming in here to do with other diseases, and we've talked a bit about Parkinson's and dementia and IBS, and we've also talked about particular conditions where FMT has been shown to be effective. Is there evidence that FMT could be useful in treating other diseases? In particular, a question here from Emma Selby: is there sufficient evidence of FMT working in ulcerative colitis?
Maybe James is aware of the trials that are currently ongoing.
Oh, so we've got about 430 odd randomized controlled trials happening globally on FMT, on everything from depression and anxiety through to, bowel cancer and everything in between. And we also have, quite good evidence in ulcerative colitis, actually. In fact, we've got, a Cochrane review just came out suggesting that in patients who are just diagnosed with ulcerative colitis, FMT is quite effective in reducing symptoms and doing it in a sustainable way. But what I would also say is that FMT is a blunt instrument currently as used. There are quite big gaps in our understanding of precisely how it works and in targeting it precisely to an individual, and also in maintaining and feeding those microbes once they've engrafted into the recipient. And actually, it's often used in those trials as a method for trying to understand how specific aspects of the microbiome work and how they influence what's going on. We are seeing really impactful trials in FMT when they're used as an adjunct to things like chemotherapy. So chemotherapy seems to, particular types of chemotherapy, particular immunotherapies that target the immune system, seem to be very susceptible to manipulation by the microbiome through FMT. It seems to be a very, very good way of reducing things like graft versus host disease and stem cell therapy. And it seems to be a very good way of flushing out antimicrobial resistance genes in the guts for patients who are having treatment who might be susceptible to infections. So we're seeing lots of really exciting advances. And I think the FMT is going to become more and more and more precise, more and more targeted, and delivered in easier ways for patients to take going forward.
Fantastic. Yeah, I found both of your presentations very positive and hopeful for the future because this is clearly an opening area. And I think one of the aspects of this was picked up by one of the questions. Bilkis Mohammed said, in terms of hyperglobal generation, do you recommend people going back to their normalized local diets or just avoid mass-produced over-processed food? And I would like to add along with that, we've got these things like the blue zone diets, where they analyze the diet of people who live in places where they have a very long-lived people. What do you both think about that? How can we make sure that we are giving ourselves the best chance by what we eat?
So, I mean, Simon, after you. This is definitely your domain. I've got an opinion, but I think you go first.
Yeah, so I am actually involved in a study looking at centenarians that have lived their lives on the Mediterranean diet. And there's been a lot of sort of anecdotal evidence that the Mediterranean diet is going to prolong mental and physical health. And so we're actually starting to analyze the microbiome in these individuals to see if there's anything unique or distinctive about them. I mean, there may well be, but we've got to, as James has mentioned, I've mentioned, we've got to look at it in the context of lifestyle and behavior as well. I mean, they're living in probably a more ideal climate than we are in the UK, for example. They may be taking less medications that could have a negative impact on their gut. Family support is probably important as well. So there's lots of other things to take into account. But it's possible that there could be a positive association there of particular microbes with living a healthier life. I mean, like James, I'd emphasize that the important years in establishing a healthy microbiome is from years 0 to around 6, when it's been established and it's sort of a template for the rest of your life. And of course, that's the window when most kids get antibiotics. So, that's really can be very detrimental. it's far easier to maintain a healthy microbiome than try and repair one later on when everything in your body is set to keeping those particular microbes.
Yeah, I 100% agree with that. And I think what we can say is that a westernized diet, so a westernized diet high in fat, high in processed meat, high in ultra processed foods, low in fiber and plant-based goods, is unquestionably a terrible diet, and we need to be moving away from it, right? So I think you can make generic statements like that. I think, you know, I spend quite a lot of time studying sub-Saharan African populations, where actually what we're trying to do is to maintain their local diet and their local kind of methods of food manufacture and food production, because that is a very important way in ensuring that they have the specific microbes that they really need in their population to maintain their health. So making generic statements about nutrition and diet is sometimes quite hard for that reason. But I'm increasingly of the opinion that actually the most important thing is exactly as Simon said, is just not to destroy your microbiome in the first place. And actually, you know, misuse of antibiotics and drugs that specifically target it, and avoiding those might just be, well, certainly it's as important, right? So I think it's about this idea of having conservationism as a strategy for protecting your microbiome throughout your entire life.
Fantastic. Protect our inner environment as well as our outer environment. Yeah. Right. Exactly. Thank you so much. Thank you for an excellent session from Anne, Simon and James. And yeah, good luck with it all. And back over to Sam.
Thank you very much, Steve, and to all of our speakers. That was a really interesting session, and it's great to see so many people engaged with it as well. So we're going to take a short break now for just under 20 minutes, so you can stretch your legs, grab a drink, come back to us at 3:25, please, and we'll get back into the final session on surgical and interventional science. If you'd like to stay put during the break, we will be showing a presentation from the Royal Society of Medicine, so do please feel free to stay and watch that. And I will hand over to Gavin now from RSM Membership, who will talk about the RSM's membership offering and how it can be of great benefit to anyone who works in medicine and healthcare.
Thank you very much, Sam. And for those of you who are staying on, I'm Gavin Berkery. I'm the head of membership and marketing at the Royal Society of Medicine. And I just wanted to take 15 minutes to talk to you about what RSM can offer you. For those who don't know much about the RSM, just some basic background information. We're a multidisciplinary organisation made up of healthcare professionals from all over the world, 19,000 members. And our aim is to share learning and support innovation. We're a charity, and we've been established since 1805. And we're committed to being a trusted voice in healthcare education and being there to promote the exchange of information on ideas of science, practice and organisation of medicine, as you're seeing very much in play this morning. We're a leading provider of high quality continuing learning for our healthcare professionals across the breadth of medicine and healthcare. And if we go to the next slide, you'll get a bit of a sense of that breadth that we cover, because we are made up of a huge variety of different sections. So if we can move to the next slide, please. Thank you. And this gives you a flavour of the various different sections that the RSM is made up of, from anaesthesia through to venous forum. You can see sections around dermatology, oncology, colon proctology. So all of those different sections are part of who we are. And so the breadth of the medical education that we provide is huge. And that's part of really what makes us unique. Can you go to the next slide, please? So how we go about delivering our mission, we share that learning, we support innovation for people throughout every career stage, starting as medical students or allied health professionals to becoming a consultant all the way through to retirement. We have members from all of those different areas of careers. Our members and event participants form an international community of healthcare professionals, and the reach of our programs is over 100 countries. Many of our programs are CPD approved, and they're delivered as webinars, hybrid and in person, usually in central London, in our fantastic building. And we've got one of the largest and most up-to-date medical libraries in Europe. And you can see an image of that behind me, where we've got access to a huge array of e-journals, e-books and medical databases that our members can access. We also publish the Journal of the Royal Society of Medicine, and we offer memberships to enhance access to these and a range of other benefits. And I'll just take a moment to go through those. If you go to the next slide, please. So we offer, in essence, 3 different types of membership: fellow membership, associate membership, and students. And this is for UK and overseas. Fellows are made up of qualified medical doctors, dentists, and vets. Associate membership is made up of allied health professionals and anyone who's interested in the delivery or practice of medicine and healthcare, and students. And we package up the different types of the benefits around learning, contributing, and networking. So we'll take a moment just to talk about some of the learning that membership affords. On the next slide, please. So we have an extensive program of events at preferential rates for our members. Our members will receive a substantial discount off of the standard participant rates, with some programs are free for members. And our webinars, in-person events and conferences cover both multidisciplinary medical education around those sections that are run through, and broader professional development. We also run a range of public engagement events, which includes public lectures and our popular topical series, such as our Spotlight sessions, where we bring global experts together, clinicians, researchers, for thought-provoking conversations on topical and groundbreaking medical advancement and research. On the next slide, please. Membership also gives you access to one of the largest and most up-to-date medical libraries, and that's available 24/7 from anywhere in the world. We've got an extensive reference library online and in print. And for those of you who are close to where we're based in central London in Wimpole Street, we've got some fantastic workspaces for you to use, including private study booths and areas for collaborative learning. The easiest way to see the vast array of our knowledge sources is to use the library discovery search, which you can look at even as a non-member. You can go on there and have a look at some of the journals and e-resources that we have available. And you can be confident that you basically get the very latest issues of a huge number of titles, such as the New England Journal of Medicine, the Lancet, BMJ, and across all of those different areas of the medical specialties that we highlighted earlier on. Next slide, please. In terms of contributing and getting involved, our society is only as strong as the contribution that our members make. So hundreds of our members volunteer to help us provide these excellent education programs and thought leading initiatives. Hundreds are directly involved in the running of the organisation, and that might be as a member of one of our medical section councils that we've highlighted earlier on, and help to develop and deliver the education programs, or as a committee volunteer strategically steering the future of the RSM. There are also lots of opportunities for you to take part in competitions, to win prizes and travel bursaries. We have prizes available for students, trainees and fellows, which can really help to set you apart from your peers. And competition deadlines run throughout the year, so you can have a look on our prizes and awards pages of our website to see a flavour of what we have available there. And we also offer to our members a range of preferential rates for different products and services, from airport lounges to discounted Apple products. So if you visit our website, you can get a flavour for what our members enjoy in that space. And then we'll move on to networking. Wimpole Street is your member clubhouse, and our members can enjoy exclusive access to our lounge, bar and restaurant. We also have a hotel on site, which is a member-only hotel, and that offers great value for money if you're looking to stay in the heart of London for a visit. Members can also make use of the facilities by booking meeting rooms or even private dining rooms. So maybe you're interested in holding an event at the RSM, whether that's a social or professional gathering, and that can be held in one of our very wide variety of meeting spaces. And we appreciate that London's not going to be convenient for everybody. Therefore, as a member, you have access to 55 reciprocal private members clubs around the world in 23 different countries. And as a member, you have access to that club network as well. As members, you just ask for a letter of introduction from us, and then you can make use of those on your visit, wherever that will be. So, on the final slide, that sort of encapsulates very briefly what we offer in terms of learning, contributing, and networking. And we'd love to have you join us to form our powerful multidisciplinary community who co-create and connect and really are transforming the future of healthcare together. And we'll drop into the chat links to the pages on the website where you can see more information about membership. And also, if you want to ask any questions about how membership could be of use to you and any more details, you can get hold of the membership team. I think the details have been put into that, so you can see how to get hold of them, whether that's by email or by phone. And I can also see, just before I log off, I can see that someone's asking about an Imperial trained GP. How can I share the recordings? Oh, okay, I think that's about the event more generally. I think that will be followed up later. The event team will supply the recording for the event. So thank you very much for your time. Enjoy the rest of the meeting. Thank you.
Okay, welcome back. Hope everybody is feeling refreshed. We're now going to go over to Georgia Sturt, who is Bowel Research UK's Research and Grants Manager, for our final session on surgical and interventional science. So, Georgia, over to you.
Hi, everybody. Welcome back to the session. And yeah, thank you so much for joining us for the final session of the Medicine and Me Big Bowel event 2024 with Bowel Research UK and the Royal Society of Medicine. I've got a group of really incredible speakers for you today. And in this session on regenerative medicine and surgical technologies, I'm delighted to kick off with Professor Richard Day. So Richard is the director of the Centre for Precision Healthcare at the University College of London. And his lab focuses on the clinical transition of technologies associated with biomedical engineering, primarily through tissue engineering, drug delivery, medical devices, and regenerative medicine. His lab has a sustained track record in the creation and application of novel technology applied to the treatment of diseases associated with gastrointestinal, cardiovascular, ophthalmology, and oncological conditions. So this spans invention, development, public engagement, clinical translation, and commercialization. And Richard is also the co-principal investigator of the AMLI project, of which I'm also a part. So without further ado, I will hand over to Richard. Thank you for joining us so much. Thank you so much for joining us today.
Well, thanks, Georgia. Thanks for that very kind introduction and for the invitation for speaking at today's meeting. So I'll share my slides. Hopefully you can see my screen, my slides.
Yes, looks right.
That's great. Okay, so thanks again, and thanks to Georgia, and also thanks to Georgia and the work with BR UK that we've been working with them together on the AMLI project that I'm going to be talking about today. So my talk today is really going to provide an overview of what we call regenerative medicine and how this is being applied in the field of bowel disease. And then I'm going to talk in a bit more detail about a European interdisciplinary project that I'm coordinating called AMLI that aims to deliver a new regenerative therapy for fecal incontinence. And then I'll finally highlight some of the challenges that we are facing along the way with these new types of treatments. So here's my conflict of interest statement. I'm the inventor on several patents held by UCL, and I'm also involved in a UCL startup company that's involved in the production and development of biomaterials used for regenerative medicine. So I think I'll start by defining what is meant by regenerative medicine. And UK Research and Innovation, which, as most of you will know, is the main UK funding mechanism for research, defines regenerative medicine as a potential revolutionary treatment for the replacement and restoration of normal tissue function.
So this can include a variety of different applications. It can include stem cell therapy, it can include gene therapy and tissue engineering, which I'll be talking about in a bit more detail. But what it doesn't include is more conventional pharmaceutical therapy, so the sorts of treatments that you might get over the counter at a pharmacy, or traditional surgical intervention or prosthetic replacements. So the concept of regenerative medicine is not new. The term regenerative medicine was coined by a US scientist called William Hasseltine on the left here, but thinking around the ideas of regenerating or replacing organs goes much further back than that. So in 1938, there was a book published called Culture of New Organs by Alexis Carrel, who was a Nobel Prize-winning vascular surgeon, and Charles Lindbergh, who was the first aviator to fly across the Atlantic alone. Lindbergh was an engineer, and he wanted to understand why his sister-in-law's fatal heart condition could not be repaired surgically. So he and Carrel went about creating an artificial perfusion pump for organs outside the body and during surgery, and their work was the basis for the development of artificial hearts. Further back than that, in the 18th century, it was observed that salamanders, a type of amphibian, can regenerate an amputated limb in several days. And going much further back than that, in Greek mythology, Prometheus has his liver eaten by an eagle during the day as a punishment, but the liver completely regenerates itself overnight. So in the context of bowel disorders, there are three main types of cells that have been investigated for regenerative medicine applications. All three cell types are what we call anchorage dependent or adherent cells. So that means that they won't survive if they're outside the body and they're not attached to a suitable surface. And I'll talk more about why that is important shortly. Each of the cell types investigated to date has its own set of benefits and drawbacks, as denoted by ticks and crosses on this table. I'm not going to go through this table in detail, but the key thing to note are each cell type is limited by either its availability or its potency in terms of how effective it is, or its safety profile. So at the moment, there's no clear-cut winner in terms of which cell type is best. So it's important to note that when we're delivering cells to the body, if we deliver them on their own, it's unlikely to result in a regenerative effect. And often structural support is needed for the cell. So in the body, normally, this supporting structure is called the extracellular matrix, as illustrated here on the left. And it consists of proteins and other molecules that provide a meshwork that surrounds and supports and gives structure set to cells and tissues in the body. So in regenerative medicine, we aim to replicate the structure provided by the extracellular matrix with materials we call scaffolds. And these scaffolds act much like scaffolding used in other types of construction to provide a framework that supports tissue building blocks, i.e. the cells, and helps to retain them in the correct location. So the key ingredients generally required for regenerative medicine are cells, scaffolds, or a combination of both of these components. So in terms of the bowel, there are a growing number of studies that have reported potential benefits for regenerative medicine for a number of different types of disorders. A large number of these involve using what we call mesenchymal stromal cells, or MSCs, that are often derived from either fats, tissue, or bone. The two clinical indications or applications of regenerative medicine we've been working on at UCL, and what I'm going to talk in more detail about today, are scaffolds being used for the treatment of perianal fistulas and the anchored muscle cells being used potentially for fecal incontinence. So perianal fistulas, we've heard a little bit about fistulas already today. Perianal fistulas are a particularly unpleasant condition. They're relatively common. They form due to an abnormal connection between the anal canal and the skin surrounding the anal opening. They're particularly troublesome in terms of they don't tend to heal by themselves. If medication doesn't work, quite often surgery is required. to try and resolve and make them heal. The surgery itself doesn't always work, and there is a risk sometimes with damaging the sphincter muscles, which control continence during surgery. So the goal is to try and eradicate the fistula tract and ensure that the fistula heals. So to investigate this, we received funding from the Wellcome Trust back in 2011 to try and develop a filler material that we can use that will act as a scaffold to allow the host tissue to infiltrate and allow the fistula to heal by itself. So we've been able to make this material to a clinical grade, and we've now been able to treat to date 10 patients at University College London Hospital, and so far these patients have responded well. We've been following them up and there have not been any adverse events reported. When we were developing the materials for fistula repair, we had to do some preclinical testing and show how cells might interact with these materials, and we discovered quite early on that the TIPS microspheres, as we call them, act very well as a substrate or a supporting scaffold for a variety of different cell types. So we thought potentially we can use these materials to act as a supporting structure for use in the delivery of cells. So there are potentially a wide range of different indications that we could use these cellularized microspheres for, but the unmet clinical need we decided to target first is fecal incontinence. So bowel continence is normally regulated by the interplay of muscles and nerves, primarily located in the rectum, anal sphincter complex, and puborectal muscle. The sphincter complex consists of the internal anal sphincter, as denoted here, highlighted in yellow, via an endoanal ultrasound. And the internal anal sphincter is composed of a ring of involuntary smooth muscle that contributes to anal pressure at rest. The external anal sphincter, shown by the outer ring on the figure on the left, consists of skeletal muscle fibers that are under both involuntary and voluntary control. So obstetric injury sustained during childbirth is a major cause of anal sphincter damage in women. And the endoanal ultrasound image on the right, you can see that the integrity of the sphincter complex has been disrupted due to a third-degree tear. Around 35% of women that have given birth experience some degree of injury to the external anal sphincter muscle, and this results in cases of fecal incontinence in around 5.5% of women after having a baby, although this figure is likely to underrepresent the true number of women that are actually affected by this condition. And around 80% of this group will have fecal incontinence with no associated nerve damage, meaning that the cause of incontinence in these patients is directly related to damage and dysfunction of the sphincter muscle. So, assuming each year around 5 million babies are born in Europe, around 250,000 women per year in Europe could benefit from treatments aimed at sphincter muscle regeneration. So as mentioned earlier, the cell types being investigated for sphincter muscle regeneration are what we call anchorage dependent, meaning they need to remain attached to something, ideally cells or the extracellular matrix, in order to remain viable. In the case of all cell therapies based on muscle cells, a biopsy is collected. The cells are isolated from the tissue and cultured in plastic tissue culture flasks, often like these, which are called cell factories. Once a sufficient number of cells has been reached, which may number in the hundreds of millions of cells, the cells need to be detached from the flasks before they can be injected into the patient. And this results in the anchorage-dependent cells being suspended in an unnatural state. Not surprisingly, many of these cells die within a short space of time. And this can be seen on the right of this, on the left of this image, where the blue dots on the top left image are viable living cells in a tissue culture flask. But when these cells have been detached and are maintained in a suspension, many of the cells die, as indicated by the red and green stained cells. And this effect has been given a fancy name. It's called anoikis, and essentially it means the cells are resulting in cell death. So to address this, we've been developing what we call implantable microsphere for the manufacture and delivery of the cells. And we've been using the TIPS microspheres already being used for the fistula study so that the cells can attach to their surface. This is so that the anchorage-dependent cells can be delivered in a naturally attached state, and the microspheres are then designed to dissolve and hopefully allow the sphincter muscle to regenerate and restore its function. So we're very excited about this approach, as we believe it could be used as an improved method to deliver cells for regeneration of sphincter muscle and other forms of tissue using anchorage-dependent cells. And in 2019, we were awarded a Horizon 2020 grant from the European Commission for a translational research project called AMELI, which will take the technology through to a first-in-human clinical study. So this is a multinational, multidisciplinary pan-European project involving academia and industry, with specialists covering engineering, manufacturing, biology, medicine, public engagement, and technology exploitation. If you follow this chart clockwise, it shows the different stages of the project progression that we've been working on, starting with the production of the clinical grade microspheres and then developing a process used for cell attachment. And after quite extensive preclinical testing, the product will undergo clinical testing in a multi-center trial. Running alongside this, we've got work packages that will be covering dissemination, and this includes work with BR UK and Georgia, as well as looking at how the treatment could potentially be exploited for other applications in the future. And this is work with Top Start, who are also on the meeting today. So if you're interested in engaging with the project, there are various opportunities to be able to do that with various partners in the project, and I'll provide some contact details at the end of my talk. So a project of this magnitude and complexity has a number of challenges that we've identified throughout the project. So one example is the logistics of shipping the product. So the product is a fresh product. It's living cells on the material. These need to be shipped around Europe. So the shipping of the clinical product from the production site from the UK to the clinical sites across Europe initially involves the collection of the biopsy from the clinical sites. These are transferred to a facility in Austria where the cells are isolated. The cells are then shipped to NHS BT in the UK, where they are combined with the microspheres before they're shipped back to the clinical sites where the patients are. So we need to take into consideration a variety of factors that may impact on the viability of the product. So this includes temperature ranges throughout Europe. So we've got clinical sites in Northern Europe and Southern Europe. And also we've had the added challenges of Brexit since the project started, which were unforeseen. But we're optimistic that we can overcome these challenges. So these are the initial goals of the project. They're quite ambitious, but if we're successful, we think that we can get a new therapy that's hopefully going to be of value in treating patients with incontinence. We think we can broaden this out from not just the obstetric injury group of patients, but to a wider group of patients, and potentially for other treatment of other bowel disorders. So in summary, we think regenerative medicine offers many opportunities for bowel disease. It's an opportunity to potentially to cure rather than manage a variety of disorders. It needs a multidisciplinary team. We can't do this as individuals or scientists or clinicians, but alone we need to work together. And obviously there will be a number of unexpected challenges along the way as we develop these types of technologies. So I'd like to finish by thanking our collaborators on the projects I've discussed today, notably Professor Charles Knowles, who's the clinical lead for the AMELI project and also the fistula study, and also our funders, without whom we wouldn't be able to do this research. And as I said, if you're interested in engaging with any aspects of the project, please feel free to reach out to either me, Georgia at BRUK, or Martha at Top Start, whose details I've put on the slide there. So thank you very much.
Perfect. Thank you so much, Richard, for a super interesting talk. We're delighted you could join us today. And we will be taking questions at the Q&A during the Q&A at the end. So next, I am delighted to welcome Sarah Laws to the session. Sarah, is your yes, there you are. Hello.
Hi.
So Sarah Laws was diagnosed with colorectal cancer in 2019 after a misdiagnosis. Following combined chemo and radiotherapy to shrink her tumour, she was offered robotic low anterior resection surgery using the Da Vinci system. Following the surgery, she decided that her talents lay elsewhere after 40 years in accountancy and has trained to be a holistic therapist, offering complementary therapies to people going through the same life events. She is eternally grateful for being offered this surgery and having a fabulous consultant in Mr. Thomas Pearson, who aided her with the information for her talk. Her surgery has given her the opportunities to be involved in various patient trials and promotions with Bowel Research UK and Cancer Research UK. So thank you so much for joining us today, Sarah. Over to you.
Lovely, thank you. You've knew enough clearly what I was going to talk about. But yeah, I was diagnosed after having 18 months of pretty horrific effects of bowel problems, and after the combined chemo and radiotherapy, I was offered the robotic surgery. One of the main reasons I took the surgery was because of what it offered me. It was a quicker recovery time. It was less invasive. It actually got closer to the site of the tumour, rather than taking away lots of healthy tissue. So on March the 20th, 2020, March the 10th, 2020, I had my resection surgery, where a vast portion of my colon and half of my rectum was removed. I was then given an ileostomy to help recovery for 6 months. That was a learning curve, to be honest. Having a bowel attached to your having a bag attached to your stomach is quite an experience. But 9 days after I came out of hospital, we went down into lockdown, the very first lockdown. So I had no medical assistance, no visits from a local district nurse, and was left to my own devices. Being attached to a bag which was very angry most of the time, and got nicknamed Moaning Myrtle because of the horrendous noises she used to make, actually taught me a bit of humility for 6 months. And I was actually sorry to see her go in September 2020. But like was mentioned before, the surgery was quite life-changing in that when you're given a cancer diagnosis, the toys go out the pram, and in the first week you're convinced that you're going to die in 7 days. So any offer to extend my life somewhat and to annoy many of my family for my very existence and for staying, I took up. And Mr. Pearson went through every eventuality, what could possibly happen. I may get sort of stranded with the bag for the rest of my life if the surgery wasn't successful. Luckily it was. I was left with virtually no marks on my stomach whatsoever. So from the point of view aesthetically, I'm not a bikini wearing person, but from another person's point of view, the less invasive form of surgery is more beneficial, because I have no marks on my stomach whatsoever 5 years later. The only mark I have is where my ileostomy was, and that is virtually faded now. the surgery has given me a new lease of life. And as was mentioned, I felt very despondent when I went back to work and felt that my talents lay elsewhere. And if I could promote the surgery and the benefits that it had given me, then I would push ahead with that. So first of all, when I was in lockdown, it was a case of deciding what I was going to do. There's only so much Netflix that you can watch and tolerate. So I started to look online towards more holistic therapies. And first of all, I did a mental health first aid course, which then led on to joining a focus group. And I didn't realise that when I signed this form to participate in future research before my operation, that it would open up so many avenues. One of the first meetings that I took part in was to do with the future funding of the robotic surgery. And then I went on to join Bowel Research UK for the All Guts campaign in 2022, giving my rather flamboyant take on everything to do with poo. I think it had a few people in hysterics, but if it's ever a specialised subject on Mastermind, I am going to be the person that takes it. This then led on to another invitation to participate as a lay member for the Amelie trials. And this is where I get, or has been involved. I have been involved in going through patient forms, questionnaires. That's opened up quite a lot of information that I found was for people who are going through surgery or a procedure. English language, I think, for them as they're going through rather a stressful time, needs to be plain, concise and clear. So I've had great fun red penning a lot of paperwork. There was one instance where I even had to look up one word because I didn't know what it meant. I Googled it, couldn't find anything remotely near what this word was, can't remember it off the top of my head. So I had to consult with my surgeon. And it was actually one of the things that you're refrained from doing after the Amelie trial is anal sex. And the word I hadn't even heard before. So I just red penned it and just put that down instead. So I think it's very important that being this lay member, I get to be in sort of the person that goes through and makes the English language a little bit more concise and palatable for people who are under this stress and they don't really know what's involved in the trial, and if they can have the clearer information put to them, the better. I really enjoy participating in the studies, the information. I get emails weekly from Bowel Research UK and Cancer Research UK. I've now volunteered at my local Helena Rollinson Centre, go to the ladies' meeting once every month. I've jumped out of a plane at 13,000 feet to do a parachute jump for them. I've actually got back on my motorbikes now, as having a stoma negated that because just couldn't get my clothes on. So from my personal perspective, Da Vinci has been a lifesaver. It has given me a little bit more longevity, and I hope that I get a few more years use out of the absolutely brilliant surgery that I had. Cannot fault my surgeon, cannot fault the technology, and I just hope and pray that going forwards it can be offered to a lot more people, to give them the less invasive surgery. I'm also a big advocate of diet and nutrition. I've been really fascinated by some of the subjects today, especially the gut microbiome. I do not touch anything processed. When I was first diagnosed with IBS all those years ago, I actually gave up dairy and meat. Haven't eaten meat since. Went on plant-based milks, went through menopause without any symptoms, and I think that it is true that what you put into your body actually reflects on your actual health and well-being. So I'm a big advocate of healthy eating, non-processed foods, fresh fruit, vegetables, lots of fibre in my diet, and hopefully it will keep my bowels healthy for a few years yet. So that's all I really wanted to talk about. The technology, I was a bit worried about having robotic surgery to start off with, and looking at the actual machine. When I was first shown it, it did sort of conjure up images of a giant Edward Scissorhands, but I was actually shown how it works and how it looks in multi-dimensional ways of where the tumour is and where the operation site is going to be. So yes, more of this technology, please, if we can have it. Thank you very much for listening to me.
Thank you so much, Sarah, for sharing your experiences with robotic surgery and all the amazing ways that you've gone on to help other patients in the wake of your own diagnosis and treatment. So now we'll be moving on to our final speaker. So I'm delighted to welcome Ms. Charlotte El-Sayed. And Charlotte is a higher surgical trainee based in the West Midlands Deanery. She is incoming president of the Jutes Club, which is the trainee society for colorectal surgery. And she has a vested interest in surgical training, innovation, and simulation. She has been the Royal College of England and NHS England robotics research representative for the past 3 years and has spoken widely regarding the challenges facing training in robotic surgery. Her PhD is in assessing training in robotic assisted surgery, also known as RAS, and is aiming to achieve a national training implementation roadmap, which will help facilitate the delivery of an RAS curricular framework. She works closely alongside the national training bodies and hopes to establish equitable access to robotic surgery training for all surgical trainees. Thank you so much for joining us today, Charlotte. I'll hand over to you.
Thank you, Georgia. Thank you for the very kind introduction. And I think it's a privilege to follow on after Sarah's brilliant talk, giving her patient perspective on robotic surgery. Just a disclaimer, so I'm also a consultant advisor for Medtronic's Touch Surgery. So just to go on, so a few of you may have seen this picture before, and I quite like starting off talks with a picture that makes everyone in the room go a bit quiet. But for those who don't know what this picture is about, so this is Dr. Oliga, and he had performed Poland's first cardiac transplant surgery back in 1987. And the procedure took him 23 hours. Okay, so this photo won the National Geographic Photo of the Year award back in 87. And it essentially shows how challenging technology was back then and how desperately they needed to have up-to-date and reliable technology to go forward. Dr. Oliga has to sit here by his patient having undertaken this painstaking long procedure because the technology was so outdated and so unreliable that he couldn't actually leave the operating theatre, and he had to sit by his patient waiting for them to recover. And you should be able to see in the corner, his poor assistant has unfortunately collapsed from fatigue. But how surgery has changed, and thankfully surgery has evolved because of technology and predominantly because of the digitalization of technology. You can see here on the left, again, this looks like a coronary bypass procedure to me, but again, open surgery, you've got the trainees and the surgeon bent over, crowded around the patient trying to get a view. Robotic surgery or the digitalization of surgery, you can see how surgery has evolved. And on the right, Sarah kindly talked about the Da Vinci system led by Intuitive Surgical. On the right here, you can see the Versius system, which was developed by Cambridge Medical Robotics, or CMR, and it's UK's first surgical robotic system. And you can see how the operating room, how the surgery itself, how it's been transformed courtesy of the digitalisation of surgery. In the top left, you can see we've got Mr. Doug Speak, who's a surgeon from Edinburgh, performing a colorectal procedure using the Versius robot. And I'm sure you've all seen robots in the press now. You know, I quite often open the newspaper or have a look online, and these titles don't surprise me anymore. So June last year, like a video game, why students excel at Europe's first robot surgery school. And this clipping was talking about how Intuitive had managed to launch the first UK robotic pilot program. In the middle, we've got Vanish Patel talking about how he managed to train an entire surgical team, which is important if you want to run an effective robotic surgical service. And it's something we'll talk about later on. Robot surgery boosts cancer survival rate. And again, this is using the Da Vinci down in the Royal Marsden. And finally, at the bottom, which I think is equally important to mention, was the UK's first national robotic programme, and that was in Wales in partnership again with the Versius, so CMR. So why robotics? Why are we all so excited about robotic assisted surgery? Well, as Sarah said, I mean, certainly from a patient point of view, cosmesis, smaller incisions, faster recovery. Us as surgeons, it makes surgery a lot easier. So you have easier dissection. You can see in the video on the right how the robot is managing to stitch a small hole on the bowel. That's actually being performed by a novice surgeon or a more junior surgeon, and that's actually technically quite difficult to do using conventional minimally invasive surgery. It's quite straining on your upper body, and it is technically quite difficult to get your stitching at the right angle. But you can see the robot could do it beautifully and just so easily. Here, the surgeon is performing what's called an anterior section, so that's removal of part of the rectum. And usually this procedure is quite challenging, especially if someone's got quite a narrow pelvis. And you can see in this video, the pelvis is quite narrow. So for a surgeon, it is quite cumbersome trying to get down and get access to the tumour. Again, the robot makes it a hell of a lot easier. The views are a lot better as well. The dissection technique, the plane in which we can go into as well. So overall, the outcomes for the patient are better. And as Sarah said, you know, faster recovery, getting to go home sooner as well. And cosmetically, it's better. And you can see again on the left, the video on the right is using a Da Vinci system. The video on the left just shows, again, the ease that the surgeon has in performing a robotic procedure. This is with another robotic system. And the advantage to the patient, so here we've got a patient saying that the robot made their recovery time for complex procedures such as endometriosis a lot quicker. And there's a study that's been led by Argwell and with Nicola Fernhead, who was previous president of the ACP-GBI. And here it reports that patients are actually willing to travel a long distance to have robotic procedures, that they understand the benefits, they're seeing the benefits, and they are willing to travel the distance to go to a specialist robotic centre. But what's the disadvantage to the robotic surgery? Well, they're expensive. So as you saw in the previous slide, the robot comes in around £2 million, and that's across the board. And obviously we're working in an under-resourced and under-resourced NHS system where funding is obviously a big issue at the moment. The other factor we need to consider is that access to training at the moment is poor. So with any new technology, you need to consider training a surgeon to perform the procedure using the new technology. And any new technology comes with a new learning curve. So it's a bit like switching from a manual car to an automatic car. You would have to learn how to drive the automatic car. You'd have to learn your buttonology, for instance, to how to use the different controls in the car in order to drive it safely. And just looking at the graph on the right, or the picture on the right, so this is from James Kinross's study, and this is probably one of the most widely quoted papers looking at, sorry, oh dear, sorry, technical glitch, bear with me. There you go, sorry. Looking at access to robotic surgery in the UK. So you can see, looking at the map, this is outdated. So this is from 2020, but the number of dots correspond to the robotic centres in England, and the size of the dots correspond to how big the number of robots were in that region. And you can see that actually access was quite sparse. To date, we have around 200 plus robotic centres in the UK. However, we are still seeing a disparity in access, with some regions such as London having many robotic centres, whereas others access being quite sparse. And then looking at training in robotic surgery, so this is intended to be a messy and confusing slide, but it essentially summarises how messy the landscape is at the moment. There are many different training pathways that you as a surgeon can choose from. And me, as a trainee surgeon, I'm confused as to which training pathway I should follow. There are training pathways which date back to 2008 from the American Association known as SAGES. And there are other more modernised training pathways that we're seeing from European associations, such as the European Association Urology, ESCP. But actually, when you look at the training front, the majority of training programs are led by the company providers. As Sarah described, a Da Vinci robot, which is designed by Intuitive Surgical. They're an American company. But at the moment, most surgeons are trained by the companies. And the other predominant companies in the UK are CMR, and now we're seeing Medtronic as well. And there are more companies that will come through as time progresses. But this, of course, introduces a problem. We have to remember that surgeons are not trained by companies, just as drivers on the road are not trained by BMW or by Mercedes. There has to be a governing body in place. And robotic surgery should equally be treated as any other modality in surgery. So exactly the same as open surgery or laparoscopic or keyhole surgery, and therefore must be trained, delivered and accredited by the surgical training bodies. Accreditation should be led by the GMC, just as it is in any other modality of surgery. We are unfortunately seeing a lack of control in robotic training at the moment, but again, that's because of how it's being driven and how it's being delivered by the robotic companies. We talked about this back in 2022. So the FOSS test, as it's called, the Technology Enhanced Surgical Training document, was commissioned by the 4 Royal Colleges in the UK and also by the UK surgical training bodies, so COPS, the JCST, NHS England. And here we basically reported that training is a problem at the moment. We can see it's progressing. We can see the clinical need. We can see the patient need. We can see it's going to continue to expand over the years to come. However, it needs to be formalized, it needs to be standardized, and it needs to be structured and delivered by the surgical training bodies. We went on to report this to the UK government back in June of last year, and we were asked to report on what our vision was for robotics in the future and how we could see expanding and affecting the NHS. And we reported that it's going to grow due to the benefits that we've described. However, there was a need for a training framework or robotic curriculum, which we would implement using a roadmap, which I'll come on to briefly at the end. So just to talk briefly about my research, so I've tried to understand what the training landscape is like at the moment, but importantly, how can we improve the training landscape? How can we standardize training? And how should we be delivering training in the future? In order to gain that understanding, we needed to approach the 4 key stakeholders involved in robotic training. And these were your robotic surgeons, including what's called the proctors. So they're the experts in delivering robotic training, and they're actually employed by your robotic companies. Your novice surgeons. So what did we mean by that? We meant the surgeons who are undergoing robotic training. And this included both your consultants as well as your surgical trainees. The curriculum developers are those who are involved in the delivery of surgical training, so the actual training bodies themselves. And finally, the robotic industry providers, so Intuitive, CMR, Medtronic, they're educational leads who are responsible for delivering training to the surgeons. And then we also include a subgroup called the surgical innovators, and they're essentially your academics and your clinicians who have a background interest in surgical innovation and therefore have an understanding as to the implementation requirements for new technology within healthcare. So this was a qualitative study involving semi-structured interviews. We conducted 27. The reason for that is because we reached saturation in themes, i.e. no further themes were identified. In the interest of time, I'm just going to talk through some of the key findings. So what were the challenges in undertaking robotic training? We've already discussed access to training. Some of the other issues, the learning curve, competing with your consultants. So as surgical trainees who want to learn to become robotic surgeons to support a future robotic service, bearing in mind that these are trainees who will be consultants in 2-3 years' time, therefore there will be an expectation that they can perform robotic colorectal procedures. They weren't able to access training because there were a number of challenges. As I said, one was access to the robot, the other one was the competition with their consultants, the learning curve required. And there were other things to consider, such as the fact that it's not in our curriculum at the moment. Therefore, there's no standardized training pathway in place. Some trainees reported they had to train out of hours. They were struggling to actually access the robot itself. And the table on the right talks about learning curve for robotic cases, so robotic assisted colorectal resection, but you can see that the numbers are quite variant and there's no standardized figures. So it's difficult to understand what the learning curve is, but understandably, the learning curve will be different depending on the seniority of the surgeon and where they are in terms of their exposure and understanding of robotics. Other challenges faced included the cost of training. So we talked about the robot costing £2 million, but you have to consider the training program itself. So taking a trainee to a robotic center, getting them on the robot, doing their basic skills, undertaking their dry lab, their wet lab, etc. The fact they need to be proctored, so they need to be observed before they can be signed off or before they can be deemed as competent robotic surgeons. There are a lack of resources at the moment within the NHS to support robotic training. There's a variation in systems. So every robotic program is different. Every company has a different program because their robot is different. So the technology learning curve required per robot will vary, and it means that each robot will have a different training program. And on the right, this is a new robot we're expecting on the market from Ethicon, and on the bottom is the latest robot from Intuitive, so the latest Da Vinci, known as the Da Vinci 5, which received FDA approval earlier on this year. The setup of your surgical services, again, you have to consider funding, you have to consider training of the wider surgical team as well, and theatre utilisation. In the UK, we are, dare I say it, poor. So we start late and we finish early. So we're not getting through as high a volume of robotic cases as we would in Europe or the US or Canada. And therefore, again, that reduces your exposure and your training opportunities. Thoughts on future training. Our stakeholders, so our participants across the groups, felt that there needed to be equity of access in order to support standardised training. Something called platform agnostic skills needs to be considered, and that's where you develop fundamental robotic skills which can be used across the different robotic systems. So across a CMR, across a Da Vinci, across a Medtronic robot. And you need to have a basic understanding of the technology requirements for training, as well as the applications of the robot. So for which procedure should we be using a robot? For which patient? So you need to have an understanding of the right patient selection, the safety aspects around robotics, etc. Who should be trained? There were mixed views. Some felt everyone, as we can see that robotics is likely to be the norm in the future, and that laparoscopic or keyhole, conventional keyhole surgery will become obsolete. And there was a feeling as well that Trainees should be trained at an earlier stage. So instead of waiting until they're consultants and taking them out of their consultant practice to train them to become consultant robotic surgeons, actually they should be trained earlier on, and the trainees should be graduated throughout their surgical training program. But importantly, there was a feeling that needs to be regulated. It needs to be owned by the surgical training bodies. However, industry would also need to be involved. Industry or the robotic companies have their own training measures which need to be adhered to. For instance, how to set up the robot, the technological safety aspects of the robot, and they have a due diligence to deliver that side of training. So any future curriculum would need to be in partnership with the industry providers. The RoboMat, the final stage of the study, which we've just completed, and this is looking specifically at the implementation of robotic training. So we all know that there needs to be a curriculum. We all know that it needs to be standardized. The big question is how, especially in an under-resourced NHS with a lack of funding. And at the moment, we are seeing that obviously the surgical service is struggling, particularly after the pandemic. So we conducted 3 workshops, one looking at overcoming the challenges in delivering training, so ensuring equity of access. The second one looking at the future delivery of training, so how it could be integrated into the curriculum, at what stage should it be integrated, who should be trained, etc. And finally, the workforce and infrastructure requirements. And the RoboMat should be available within the next 2 months. Other studies coming from the college, so Mastery you may have heard of. So this was funded by Intuitive Surgical. It was led by my supervisor, Professor Simon Bark, who's Chair of Research at the RCS for Robotics. And this was basically looking to see how your minute measures, what we call your APMs, your automated performance metrics, which are recorded by a Da Vinci robot, how they can translate to clinical outcomes. The bottom graph shows what's known as an expert surgeon or a proficient robotic surgeon. You can see their movements are very precise compared to your learner surgeon, where the movements are very haphazard. And the understanding or the hypothesis is by analysing each minute APM or automated performance metric, you may be able to predict clinical outcomes in terms of, for instance, leak rates for colorectal anastomosis, etc. So this was a UK-wide study, and they recruited over 500 cases. Other studies coming from the college as well, Reinforce, which was led by my other supervisor, Professor Marion Campbell. This was another qualitative study, and it was looking at barriers, facilitators, and how they affected wide-scale implementation of robotics. And they looked at 3 phases of implementation, so your pre, early, and late, and looked to see what was affecting your implementation. So, for instance, in your pre-stage, looking at, for instance, cost was affecting implementation, the ideology that it may not be for future practice, and looking at your later stage of implementation robotics, things like maintaining your costs, institutional promotion, and just trying to understand whether or not this had a long-standing benefit to an NHS service. So this is a study that's still undergoing. So I'd like to thank the supervisory team. I've already mentioned Marion and Simon, Chris Munch, who's my supervisor from NHS England, and the brilliant Layla Retainers from the University of Bristol. And thank you to all my sponsors, including Octopus, NHS England, and the RCS. And I thank you for your time.
Fabulous. Thank you so much, Charlotte, for talking us through all the amazing work that you're doing to get both surgeons and patients access to robotic surgery. I'd like to invite Sarah and Richard to switch their cameras back on for the Q&A session. And we're going to start off with a question for Richard. So could this technology used in Amelie be transferred for women who may currently need a vaginal mesh surgery? Is that one of the other kind of intervention or indications rather that you could foresee the anchored muscle technology being used for?
I think it's possible that similar technology could be used for this. But I think in the current format, what we've designed for the Amelie project is essentially little tiny beads of cellularized microspheres that will be injected. So they won't necessarily form a structure that would provide support along the lines of the mesh-like structures that have been previously used. However, I do think, and we have started to look at this separately, that regenerative medicine could be used as an alternative to meshes. So they could be more sort of biological, tissue engineered constructs that could be used for that type of indication. So it's certainly the principles that we're using in Amelie could be transferred to something similar, but there might need to be a few adaptations to make it work properly in the way that we'd want it to for that type of indication. So yeah, it's certainly possible.
Thanks so much, Richard. The next one's for you, I believe, Charlotte. So Elena is asking, do you find that there is less blood loss and less need for blood products for patients after robotic surgery compared to other forms of surgery?
It's a really interesting question. So because the robot helps with your views and with access, so you have better access, you have enhanced views, you're getting really close to the tissue planes. In theory, you should have less blood loss. However, it all comes down to better dissection, I would say. In terms of whether or not you have less use of blood products, that I can't confidently answer. But I can say that because of how close you are to the planes and that precise view that you're getting, the precise control you're getting of the instruments as well, in theory, yes, you should have less blood loss.
Thanks so much, Charlotte. Sarah, one of the things I wanted to ask you after your amazing talk was, what was there one thing that really stood out for you when you were being offered robotic surgery as an option compared to traditional surgeries? And yeah, how did your consultant explain it in a way that made you feel so enthusiastic about it?
I've always been slightly different and wanted to do things differently. I think it's being an only child, and I think it was the fact that it was such a pioneering surgery. He sent me away and said, Google everything that you can find out about Da Vinci, and if you're happy with it, to go ahead, go ahead. And I can remember sitting in the consultation room and I said to him, as long as it doesn't go rogue like a Will Smith robot, I don't care. But I was horrified when I first saw it because it's such an intimidating machine to look at visually. But having gone on that talk after my operation and seeing the complexities and how Charlotte said it gets closer to the site, it doesn't take away as much healthy tissue. The recovery time is quicker. There is less blood loss, less abdominal pain, and you get discharged from hospital quicker. It just ticked all the right boxes for me. And being scared of having a cancer diagnosis, I was literally holding out for that lifeline, that rubber ring to be thrown to me. And Da Vinci was that rubber ring. I was just treading water. And they're the reasons why I took it, and I'm eternally grateful that I did. It's somebody once said to me, would you turn back the clock and change your diagnosis? And I categorically said no, because I've had the experience of using such wonderful technology. I've met some fabulous people on my trip. I've been part of so many things that I would never ever have contemplated if I hadn't given this surgery a thought. So yeah, it's hands down winner for me all the way.
Well, what a wonderfully positive attitude to take towards your diagnosis and the treatments you've been through. I think we have time for one final question from Barbara. So in comparing robotic and conventional surgery, what's the kind of degree of difference in terms of recovery time that people might experience?
Shall I take that, Georgia?
Yeah, so sorry, that was another one for you, Charlotte. Apologies. Yeah.
So the data we have at the moment is preliminary. So we don't have enough data out there to say that there is a significant difference in length of stay between robotic and laparoscopic surgery. However, we are hearing from patients that they are reporting less pain, quicker recovery, smaller incision sites as well. So at the moment, we're still in early stages, but that's because in the UK, we are more so early adopters compared to Europe and the US. So it's certainly something we expect to see in the future. But yes, certainly robotics, I'd say, is growing in practice. And I can certainly see it superseding laparoscopic surgery in the future, just because of the benefits we're seeing as surgeons. Yeah.
So just a quick follow-up question for that. What is laparoscopic surgery for people who might not have come across that term before?
Thank you, Georgia. Sorry. So it's your conventional keyhole surgery. So it's a bit like using chopsticks, I suppose, so straight sticks into the patient or graspers through ports. And it's something that came in the late 90s, and it's been our common approach now to surgery. It's overtaken open surgery, but now surgery has evolved again, and now we're using the robots. It can do the same as laparoscopic surgery, but better.
Amazing. Well, thank you. Thank you so much to all of our speakers in this session, Richard, Sarah and Charlotte. It's been a wonderful experience hearing all of you speak about your experiences and your research. Thank you so much for giving your time to us today. And I will hand back to Sam.
Thank you, Georgia. Thanks, everybody. So final words then. I mean, what a brilliant afternoon that it's been. And I always learn so much from patients and researchers alike, just because it's so good to hear both perspectives and find out more about living with different bowel diseases and all of the work that's been done on research into these conditions to find cures and treatments. And I feel really privileged that all of our speakers shared their work and experiences with us today, and also really privileged that so many people chose to come and spend your afternoon with us. So thank you. If you've enjoyed yourself and learned something today, please consider making a donation to Bowel Research UK to help us to continue funding research into bowel cancer and bowel disease. You can you can do this and find out about more information about the charity and our patient network part or people and research together at bowelresearchuk.org. As a reminder, members of the PART network get the opportunity to help shape future treatments and care through focus groups, surveys, reviewing documents and so on, as Sarah explained, as people with lived experience. And you'll also find out about the latest developments in research and be giving back to the healthcare community, being part of that patient community, and getting the opportunity to take part in Bowel Research UK campaigns, sharing your patient stories, and also being the first to find out about events like this one. So please do join us in the PART network using the QR code that you can see on the screen now. There will also be a feedback form sent around for this event, so please let us know what you thought about it. And if you have any questions about Bowel Research UK or the PART network, you can email me. That address is on the screen as well. So I'd like to thank our facilitators, Julie Thompson, Stephen Rowley and Georgia Sturt, and of course our speakers, Helen West, Linda Griffiths, David Humes, Anne Skinnerton, James Kinross, Simon Carding, Richard Day, Sarah Laws and Charlotte El Sayed. And a big thank you to everyone at the Royal Society of Medicine for collaborating with us on this event and helping it to go so smoothly. And of course, thank you so much for coming to the session today. It's been such a pleasure spending this time with you, and I hope to see you again soon. Bye for now.